And Abdallah Karame, who's with us from Venezuela. Professor Seidman is unable to attend due to the war in Israel. He's unable to fly out, so we will be presenting his video recorded, and we're wishing him the best for safety for him and his family. We're going to start with the patient story number 3. It's Angelica Erskine, and if we could play her video, we'll look at the story.
Hi there, my name is Angelica Erskine. I'm from Morgan Hill, California, and I began experiencing symptoms in my mid-20s, but it took nearly 5 years to receive a diagnosis of stage 3 endometriosis. In 2019, my body started changing in pretty drastic ways. I developed extreme bloating where I looked 6 months pregnant and constipation that I've never experienced before. My hair started falling out and prematurely graying. My energy levels tanked and I began having depressing thoughts almost daily. I started living in a body that I couldn't recognize anymore. Over the years, my symptoms became so debilitating that I contemplated suicide every single day for years. I stopped recognizing the person in the mirror, and I felt like I was living in a completely different reality than everyone else around me, which was extremely terrifying and isolating for me. I used all of my leftover energy to continue to find answers. I worked with 7 different holistic health practitioners who sold me supplements that never helped, multiple MDs who gave me antidepressants, prescriptions, endocrinologists. I did a full body MRI that showed nothing, fertility specialist, therapist, cognitive behavioral therapist. And I also kept researching how to treat my symptoms because they were so debilitating and I was so desperate. And every single practitioner told me something different. The contradictions were overwhelming. It left me confused, drained, and financially devastated. Over the years, I spent more than $30,000 out of pocket trying to find an answer. And after every single appointment of someone telling me that things were looking fine or that things were on the up and up, even though I didn't feel any different, I would just crawl into a ball and shake and cry for hours. And this cycle repeated for years. When you're sick for that long without a diagnosis, you start to doubt yourself and blame yourself, and it completely reshaped my entire identity. It affected my marriage, my friendships changed, my family members told me that I was just being dramatic, and I stopped making plans because I couldn't imagine a future that didn't include extreme fatigue and feeling uncomfortable in my own body. The turning point for me was after begging my OB to refer me to a fertility specialist, yet another fertility specialist, who referred me to Dr. Nezhat for endometriosis. I was super hesitant to go because I had never suffered from period pain or any mild pain from my period in my entire life. But endo was seen via ultrasound at my first appointment, and then it was confirmed with surgery, stage 3, all over my digestive tract. When I woke up from surgery, the amount of relief was almost overwhelming. I finally had an answer. What I want healthcare professionals to understand is that endometriosis is not just period pain, as I never had any of that. It's a systemic disease that affects every part of a patient's life and body. When patients come to you, many of them have already been dismissed or minimized or told that they're just over-exaggerating. You may be the first person who has the power to interrupt that cycle. What I needed most was to just feel believed. What keeps me hopeful is how much awareness is growing around endo. I have a social media platform with nearly 300,000 followers at Cook with Angelica. And when I finally started sharing my story and showing photos of how my body was changing, which was really vulnerable and embarrassing for me, to be honest, I received literally thousands of messages from women who said that they're experiencing the same exact symptoms that I went through for years. That tells me how many women are still searching for answers, and I've encouraged thousands of women to pursue endo treatment. I'm hopeful that more specialists will dedicate their careers and lives to this disease so fewer women have to endure what I did. 3 months after my surgery, after years of infertility and debilitating symptoms, I became pregnant unexpectedly. I'm currently 18 weeks with my miracle baby girl. My greatest hope is that if she ever faces this disease like I did, which she most likely will, she will grow up in a world with faster diagnoses, better care, and doctors who listen the first time.
Thank you so much for choosing this work. Thank you for listening to these patient stories. For people like me, your work is the reason why we get our lives back. Thank you so much.
It's a fantastic story. It's one that we unfortunately hear so much, and just it's unbelievable in this age that women can have pain this bad, where endometriosis is likely the #1 cause and it not be considered. So it's really moving to hear that from her. Yeah.
Good afternoon. I have the pleasure of announcing Dr. Linda Giudice, who is a distinguished professor of obstetrics and gynecology and reproductive sciences at the University of California in San Francisco. She's a biochemist and a reproductive endocrinologist specializing in endometriosis, adenomyosis, ovulatory disorders, and infertility. Her research, in collaboration with Dr. Nezhat, focuses on multi-omic approaches to looking at function and dysfunction of human endometrium in health and disease. She has mentored over 320 students, fellows, and faculty, authored more than 350 peer-reviewed publications, and is co-editor of 7 textbooks on women health, endocrinology, environmental health, endometrium, and endometriosis. She has received numerous awards acknowledging her contributions to science, medicine, and mentoring. Dr. Giudice is a past president of the American Society for Reproductive Medicine, Society for Reproductive Endocrinology and Infertility, World Endometriosis Society, and International Federation of Fertility Sciences Societies. She's an elected member of the U.S. National Academy of Sciences of Medicine and has been a major supporter of EndoMarch since its inception. Dr. Linda Giudice.
Thank you so much. It's really a delight to be here today and for this whole meeting. And I want to thank the Nezhat brothers and also AGCES and its staff for the opportunity to talk about today the pathophysiology of endometriosis associated infertility, integrating AI diagnosis and AI into infertility management. So we're going to start off with reviewing some of the pathophysiology of endometriosis-related infertility, but please bear in mind that the endometrium is just upstream from the decidua and its interactions with the placenta and pregnancy, much as Professor Venizelos spoke just before lunch. And then we'll review AI in endodiagnosis and in infertility care. And this is my favorite part, is the concept of the medical digital twin, which is just starting to blossom. So this will be quite a whirlwind tour in the next 14 minutes. So endometriosis, you all know, is a complex estrogen-driven progesterone resistant, progressive, systemic, and local inflammatory disease where the lining of the uterus is found elsewhere where it shouldn't belong and results in sterile inflammation, fibrosis, pelvic pain, and other symptoms. It affects about 10% of menstruators and up to 50% of women who have the diagnosis of infertility. And those who have endometriosis in general have about 2 to 4-fold increased risk of infertility just having the diagnosis of endo compared to those without disease. And there are variable symptoms and comorbid conditions. And essentially endometriosis, as I see it, is in addition to by the quality of it being a heterogeneous disorder, is that it is the poster child for precision medicine. And that is to tailor diagnosis and care at the individual level. And those components on the right-hand side of the slide include multi-omics, genetics, electronic health records, exposures and exposomes, and a variety of other experiences, as well as socioeconomic status. So with regard to the pathophysiology of endometriosis-associated infertility, I think the key concepts here really are inflammation. No matter what fluid is measured, peritoneal, follicular fluid, in the lesions, in the circulation, and in the ectopic endometrium, there is a pro-inflammatory signature. Increased cytokines, and also now as we do single cell analyses, even more so looking at the different immune cohorts that are different, and especially macrophages that have basically lost their ability to do what they were made to do, and that is to clean up the retrograde menstruation that occurs in 90% of menstruators and is efficient in most, but not those who have endometriosis. In addition, there's enhanced estrogen signaling and also disrupted progesterone signaling, which we call progesterone resistance. Now, progesterone itself is an anti-inflammatory. So if you inhibit it or modify its actions, therefore decrease its anti-inflammatory properties. And usually progesterone and progestins oppose estrogen, and those then can have decreased opposing actions to estrogen. There's also enhanced estrogen signaling via a different kind of estrogen receptor, ER beta, that in the end result in pain and infertility. And there are many, many, many dots to connect between that statement and the appearance of pain and infertility, some of which we know and most of which we don't. The goals of treatment overall are to decrease inflammation, restore normal hormone signaling, and for those who have infertility, also to restore infertility to restore fertility. So if we look at big data, and there's so much big data around, these reveal multi-organ dysfunction for fertility and pregnancy outcomes. If we start with the endometrium on the left side, the ectopic endometrium doesn't decidualize well, it doesn't respond to progesterone well, which is key to establishing pregnancy and maintaining pregnancy and for an appropriate pregnancy outcome. With regard to ovarian function, there are fewer eggs retrieved in IVF. However, most of the embryos do implant, not all, and many patients have positive pregnancy, so clinical pregnancy rates are comparable to those who do not have endo for the most part. In pregnancy, as we learned from Professor Venizelos, there's increased risk of miscarriage and also placenta preeclampsia and preterm birth. So this is what we know about endo's impact on fertility. It's quite significant. And for those who are fertility specialists, I think more now in the last 2 to 4 years or 5 years, endometriosis is gaining its stature as a comorbidity of infertility. So we've talked a lot in this meeting, and we'll certainly talk more about diagnosing endo. But I just wanted to say that the relevance of pelvic ultrasound for fertility is very important. If a diagnosis of endo is made during ART treatments, there are a higher number of inseminations and IVF cycles and lower pregnancy rates. And these data have just been summarized by the reference shown here. An ultrasound can also provide a cause for the infertility, possible surgery, GnRH analog therapy prior to an ART cycle, correlations with lower ovarian reserve to empower patients to consider fertility preservation, and also to assess the accessibility of the ovaries for egg retrieval, and to do an antral follicle count, look for adenomyosis, look for fibroids, and to assess the uterine cavity. So ultrasound is a very important tool. So isn't that enough? Well, there's another omics that we don't usually think about. It's sort of the new kid on the block, and that's radiomics, which is a family member of AI, machine learning, deep learning models. It's basically a non-invasive approach to diagnose or predict endometriosis using ultrasound. And it's very aspirational. We're still in early days, but the bulk of the information that we have comes from the oncology literature, where in radiomics, features are extracted from ultrasounds. For example, the shape of something, the heterogeneity, the sizes of the ovarian follicles, the 3 dimensions. And then to quantitate the imaging, not just counting the number of follicles, but to take the whole scan, to quantitate that imaging data for regions of interest, and then for the whole ovary, or in the case of oncology, the whole tumor disease. And then after quantification, patterns are analyzed, and then correlations are associated with clinical outcomes. That's pretty revolutionary. Some features correlate with molecular data and disease aggressiveness. We don't have that yet in endo, but I'm hoping that we will. Also, to predict treatment response and biomarker discovery directly linked to genomic, transcriptomic, proteomic, and other omic data. So this year, there was a systematic review about radiomics and endometriosis in terms of diagnosing endometriosis using deep learning models. And the accuracy was pretty good. Area under the curve, approximately 0.9. And there was an automatic extraction, complex spatial patterns effective for imaging-based classification and lesion segmentation. Machine learning models didn't do quite as well, but they did pretty well, and were effective in predicting modeling and risk estimation. And overall, sensitivity of 0.8 to 0.92 and specificity 0.7 to 0.9 improved diagnosis with AI versus traditional methods. Now, there are other ways to diagnose endometriosis, and there are, I think you're all aware of some of the non-surgical approaches using blood, menstrual blood, or endometrial biopsy, peripheral blood, or saliva. So the current ones are the endo test, microRNAs, the receptiva, endometrial biopsy looking for BCL6, which is a marker of inflammation, and also Heranova, which is a blood test. And these are still, for the most part, in development with regard to some of the blood tests. Now, as I mentioned earlier, endometriosis is quite heterogeneous. So in our group at UCSF, we look to the electronic health records. Now the UC system that has UCSF and 5 other academic medical centers and hospitals has a huge database that's all been put into one system. And so we did a cohort study of 5.5 million UCSF patients, 19,000 of whom had endo, 15,000 of whom had pre-diagnosis of symptoms, and 19,000 controls. And we looked for what might be associated with endometriosis diagnosis in that cohort. And then we validated it in the UC-wide 8 million patient of 25,000 endo, 25,000 controls. Bottom line is that we found over 660 comorbidities through the electronic health record, some of which are known, and I'm sure you all see it in your practices. This is reproducible in the independent cohort, and we found mainly GI symptoms, and however, there were other predictors. And then we did clustering, and that really underscored unique subgroups and also disease heterogeneity. And so the clusters, as you can see here, this happens to be for cancer and pregnancy-related subsequent diagnoses. Some patients had thyroid disease, some patients had migraine headaches, much as we see in our practice. So EHR is another layer of the precision medicine approach. Now, with regard to management of endometriosis-associated infertility, there are various management approaches, as you know. Ovulation, ovarian stimulation, IUI, laparoscopic surgery, IVF, and so on. However, arriving at a treatment plan needs to consider the duration of infertility, patient age, ovarian reserve, genetics, coexisting contributors to infertility, and comorbidities, patient preferences, and cost. And the U.S. National Academy of Medicine put out a report about the complexities of many complex disorders and said the accumulation of data has created a situation where healthcare providers are responsible for interpreting, aggregating, and synthesizing data far beyond human capacity. This really is an endorsement for AI. So I'm not going to go into a lot of detail for AI guiding ART cycle management, just to say that there are data to show that AI can enhance ultrasound prediction of egg retrieval, fertilization rates, implantation rates, and even days of trigger. In the future, extracting ultrasound image features and using advanced technologies, as well as, of course, the well-established embryo morphokinetics, combining it with genetics and also markers of endometrial receptivity, will lay the foundation for predicting fertility success and hopefully pregnancy outcomes. So I want to conclude with the concept of the medical digital twin. Currently, best practices are that healthcare providers interpret data, and there is a lot of data out there. And the result is that we have generalized treatment approaches, not really personalized care. So a potential solution is from engineering, and this is an application called the digital twin that now is being looked upon as the future in medicine, and so adopted as the medical digital twin. So here is the patient and her multiple data modalities. So data here, and there is a component of developing a digital twin where all these data at every level are then integrated and quantified. And then an algorithm is built in which it's called a patient in silico model, where the digital twin is the in silico model of the patient with all of her experiences, diagnoses, treatments that were successful or not. And then there's an AI interface that brings this back to the healthcare team and to the patient to make diagnoses about what to do next. And this cycle can be repeated as new patient data become available for that patient, synchronizing the patient and the patient in silico twin, so that then the patient will have individualized healthcare. This is a huge dream, and I hope it will be successful. So, precision medicine approaches are evolving rapidly, and the future, I think, is now. We need data, lots of data, and well quantified and the metadata that go along with those data are very important. And we also need AI, machine learning, deep learning, and other approaches to really realize the dream of personalized medicine. So I would like to thank you all for your attention and to acknowledge my colleagues at our UCSF Stanford Endometriosis Center, as shown here. Thank you very much.
Well, first I want to say thank you for Nezhat brother for making this majestic event. And our next speaker is going to be Dr. Kazem Nouri. He's a medical director of the Kinderbush Burgerland, I hope I said it good, president of the Australian Society of Sterility, Fertility, and Endocrinology, professor at the Medical University of Vienna. He has read more than 100 scientific papers. And in June 2021, he was awarded with the MBA degree from the Vienna University of Economic and Business. Dr. Kazem is going to speak about how artificial intelligence improve IVF outcome in patients with previous failed IVF associated with implantation failure. Dr. Kazem.
First of all, thank you very much for your kind introduction. And yes, you pronounced it perfectly. You know German? So let me start my lecture with thanking Professor Kamran, Farr, and Sina, Nezhat, and the scientific committee for inviting me here. And all of us started our day today with one thing. We started it, we did the same thing, all of us. And I'm not talking about brushing our teeth. What we did, we started our PC or any electric device we have. And I think if you can remember in the 90s, when we started our PCs, we could even see the different steps in the computer, and sometimes we were able to hear it. So there are processes, there are programs, and this program would run in the background of the computer, and they would interpret it and they would be executed on the basis of a binary system. If everything went okay and has been executed correctly, the final result of that was the computer was working and we all were happy. We pushed the start button and then we had the picture. In between programs, binary system. Do we have in reproduction also a button, start button? The answer is yes. To my opinion, in the moment a sperm fertilizes an egg, the process, the program, they start. Why don't we go a step back and compare the whole reproductive system with a PC, with a computer? In this comparison, I would say the hardware would be the reproductive organs, uterus, ovaries. I would say the software would be the chromosomes in the sperms, in the oocyte. The code would be the DNA on that chromosomes. And of course, we need power supply, in this case, cellular energy, which is the mitochondria. Again here, pushing the start button, fertilization the egg, till we have the implantation, there are many steps, many programs which has to be executed and interpreted correctly. Again, we have done an image, like in the computer. But sometimes we would see also in our daily life, if we have a virus, then this program would not go well. Maybe our lifestyle, cigarettes, alcohols, but the same thing can happen so that we don't have the implantation. And this is also the case when we transfer beautiful embryos. The patient asks us, you told us you transferred the beautiful embryo, why am I not pregnant then? I show them these pictures, you know who they are. Nobel Prize in Physics 2020 went to these persons because of their interpretation of the black hole. And dear colleagues, black hole in reproductive medicine is implantation. It's not that easy, apposition, adhesion, invasion. I saw today Professor Simon, who published this very beautiful paper in Nature, trying to explain, and he explained a lot about the implantation, but I think he would agree with me that the more we understand about the implantation, the more questions would come up. And the other thing is, in our job, reproductive medicine, we are not talking about the fertilization in vivo, where the oocytes goes the whole way back to the uterus and get implanted, but we have an oocyte which is being fertilized outside of the body, in vitro fertilization, and we give back this embryo, then we hope to have the implantation in the uterus. So let's go back to the black hole implantation. We don't have a good definition of implantation failure. But before going to that, let's define some other definitions here. We have the biochemical pregnancy, if we have a positive HCG in a patient, but still we don't know. What does it mean? Where is the pregnancy? Is it within the uterus? Is it outside the uterus? The implantation rate means a gestational sac per embryo transfer, and we use that because we think in our field, reproductive medicine, as I mentioned before, the fertilization is outside of the body in the lab, and we perform the embryo transfer. This is the real interpretation of the crosstalk between the embryo and endometrium. And if we don't have the implantation, that means we have here an implantation failure, something went wrong. Again, go back to the example I give to you. We have the good quality embryo, we have good endometrium, or something in between. The program didn't function so that the embryo was not able to implant. If it happens more than one time, 2 times, we have another definition. We refer to it as recurrent implantation failure, which is also not very easy. That's the reason ESHRE 2025 very recently tried to give an interpretation to it. First of all, we have to take into consideration that the age is very important. That means implantation failure, recurrent implantation failure is very different to a patient at the age of 35, age of 45, age of 25. The other thing, right now, in many countries, they are transferring euploid embryos, and it makes a huge difference. Look at the numbers here. Again, the patients under 35, in cases of transferring an euploid embryo, and in cases of transferring of non-euploid embryo. So there are countries which is allowed to perform PGT. In my country, where I come from, Austria, it's not allowed under special conditions. So that you can see, you cannot compare the definition of recurrent implantation in these countries with each other. And according to the age of the patients, according to the number of the attempts, you should intervene, you should start to find a reason for that, or you keep doing it, as you can see here. Basically, if you transfer 2 good embryos, I'm not talking about euploid embryos, and if the patient doesn't get pregnant, then you should start to think about what could be the reason. And also, according to the ESHRE publication, as you can see here, we have a lots of reasons and we have a lots of interventions which we can do and find and hope that this time it will help. So with all this now, I come to the end of my interpretation. How can AI improve implantation in the future? When you talk about the future, it's a little bit of challenge because you don't have that much publication in regard of the future. But I found this publication and I think it's very good. I'm going to go step for step with you. At the beginning, it's a very easy slide, but you will see at the end, it's going to be a little bit complicated. I enjoyed the last lecture we heard together. It was very interesting to talk about the different kind of help we can get from AI. But I think we are all doctors here, and I think the very first step, at least in our field, is the first conversation we have with our patients. I normally take like 1 hour in my office in order to ask all the different questions, make the vaginal examination and vaginal sonography. So I think it goes way back. That means I think AI will help us with that. Patients will answer all the questions and will send it to us, and AI will summarize it for that and maybe emphasize some points that could be already, without seeing the patients, the reason for infertility. It's sometimes very difficult for the patients to come to the center. For example, for a semen analysis, you always need a semen analysis if you have a case of infertility. I'm not talking about the future, I'm talking about the present time. This device you can see is an iPhone, and you can order it, and putting a little bit of your ejaculate on this system will help you at home to see your own semen analysis. So this is the first step. For that, you don't have to go to a lab anymore. When you start with stimulation, there are many things you have to consider. Before that, the AI summarizes a lot of information, as we heard before, for us. Which doses, which medication, the time of the start. And then, I just came from New York yesterday from Cornell. Every 2 days, they order the patients in order to perform vaginal sonography, in order to get some lab results, E2, LH, FSH. I'm still not talking about the future. I think it's in 1 year. The first picture you see, we have patch now for diabetes, we have patch for cortisol, we will going to have patch for measuring LH, FSH, A2 during the stimulation. How about vaginal sonography? Well, in this country, in New York, you can obviously go by metro to the university hospital, to the offices of the doctor and get it done. But there are countries like in Australia, they have to fly 3 hours in order to get examined. So this device you can see here, vaginal probe, connecting with a tab, this is not future, this is today. The patients get educated to perform the vaginal sonography, the pictures go to AI, and the information is going to get to the reproductive medicine doctor. So I think during the stimulation in the future, there is no need for the patients to come to the office of the doctor. At what time we want, of course, to prevent the premature ovulation? At what time we start with antagonists? Measuring all these factors I mentioned before, AI will tell the patient at what time you should start with antagonists. Very important point for us reproductive medicine doctors is when to perform triggering. Again, triggering is measured by AI. The patients, according to her device, I should do my triggering tonight at 10 o'clock. We'll put in connection with the center and they will tell her, okay, let's do it. AGCES is being already performed by some devices. And very important is embryoscope. That means after getting the eggs and fertilize them, they are in an incubator. Every 5 seconds, a picture is being taken, so you can see the whole process of the development of embryo for the 5 days. And according to which, in the future, I think PGT would not be necessary. All these together with the medium around the information we can get from the medium, all this will go to the case that we can perform the transfer and have the right support for the patients. And with this, I come to my conclusion. Our field of reproductive medicine is very young. Louise Brown was born in the year 1978. What we do today, it is unbelievable within the very short period of time. So imagine the next 40 years, what is going to be done in reproductive medicine. With this, I thank you very much.
Thank you very much for this wonderful overview and for finishing to the second on the timer. So next we have, this is going to be a recorded presentation from Dr. Seidman, who, as I said, was unable to travel due to the ongoing war in his country. Professor Danny Seidman is at Tel Aviv University in Israel. He's a senior physician in the IVF unit at Asuda Medical Center in Tel Aviv, the co-founder and CMO of AIVF, a company that developed an AI-based platform for IVF. He's an associate professor and director of the annual course on human reproduction at Tel Aviv University, and he completed a fellowship in reproductive surgery at Stanford Medical Center, 2 times winner of first prize at the AAGL Golden Hysteroscope competition, and published over 300 research papers and several books on human reproduction and advanced endoscopic surgery. The presentation will be when to do egg freezing in younger and older patients with endometriosis. Can AI help? Can someone begin?
My name is Daniel Seidman. I'm a professor of OBGYN at the Tel Aviv University and also a practicing physician at the Asuda Medical Center. And I would like to thank the Nezhat brothers for inviting me to talk in this prestigious endometriosis meeting. And I apologize for not being able to provide this presentation in person. The topic of my lecture is when should we freeze eggs in younger and older patients with endometriosis, and with specific reference to whether AI can help. It's well known that endometriosis can inflict damage on the ovarian cortex in multiple ways, directly to chronic inflammation, damaging the follicles in the ovarian cortex, and indirectly by oxidative stress. Also, we know that the presence of endometriomas can have a bad influence on the ovarian reserve, but surgery for removal of this cyst is even a further concern. And as you can see, there are multiple types of energy that we apply on the ovarian cortex, and they all have damaging potential on the ovarian reserve. It's interesting to note that the removal of endometriomas from the ovary causes much greater damage and decrease in AMH, as this graph shows, compared to just removing a dermoid cyst or a functional cyst. So surgery for endometriomas has a much greater impact on the ovarian reserve. And this is because the damage is not only by direct removal and terminal injury to the ovarian cortex, but also there's damage to the vascular supply of the ovary, and there's also fibrosis, scar tissue formation in the areas of the surgery, and they all result in a lower ovarian reserve. There's an interesting theory developed by the group of Professor Mairov at my medical center at Sheba, where they suggest that the surgery causes an acceleration in the decrease in the number of follicles in the ovaries, and they call this the burnout theory. It's pretty similar to the concept where you do a wedge resection to a polycystic ovary, and you get a much more significant decrease in follicular activity than expected. So this definitely requires further study. When we talk about endometriosis patients and the question of fertility preservation, we usually divide them into younger patients, which are 35 years or younger, and those with a more advanced age. We know that younger patients have many more follicles and eggs and better quality of eggs, and this suggests that in some cases fertility preservation can be delayed or can be even avoided, even when the patient is planning to undergo surgery. But again, you need very personal advice in these cases. You should consider the presence of bilateral endometriosis, when we know that bilateral surgery can even result in menopause in younger patients, and our expectations with the patient will need repeat surgeries, and also did she have prior surgeries, and of course the present position, the condition of her ovarian reserve, where we estimate by measuring AMH levels in the blood and antral follicle count by ultrasound. So all these variables come into our consultation when we have to decide the need for fertility preservation in younger patients. In older patients, the decline is so significant that there's usually no question that the patient who's planning surgery and her age is over 35 will benefit from fertility preservation. And again, the question here is not so much whether we should do fertility preservation, but more at what point is it futile? At what point does really we miss the point and it won't help her? And this graph shows you why this concern is so significant, because even when you freeze 30 eggs in younger patients, you can promise them a very high chance of live birth. But in older patients, even freezing 30 or more eggs doesn't really promise a live birth. This is another example. If you freeze 10 eggs in a 35-year-old patient versus 16 eggs in a 38-year-old patient, only 3 years have passed, but you need 60% more eggs in order to promise a 50% chance of a live birth. And delaying, any patient delaying childbearing, especially one with endometriosis, should be made aware of the possibility of and need for fertility preservation. We developed a calculator with Daniela Gilboa, an embryologist at our lab, and we were trying to form some kind of a calculator whereby putting in the patient's characteristics, you can advise her on the number of eggs she will need in the future. And this is an example using the calculator, suggesting the number of eggs and the number of cycles of embryo transfer in the future she will need for a 90% probability of live birth. And you can see that in many cases, repeated cycles will be needed in order to offer a realistic chance of pregnancy. So how many eggs should you freeze? Again, based on our model, if you, for 90% chance of live birth, you need about 20 eggs for a 30-year-old, 36 eggs for a 35-year-old, and 60 eggs or even more for a 40-year-old. AI has come in a big way into reproductive medicine and can help us in many, many ways. In reference to endometriosis and egg freezing, AI can build a model that integrates multiple variables like age, AMH levels, FC counts, BMI, and so on, and thereby predict the number of eggs we can expect to obtain and the chances that we'll actually have a live birth through this fertility preservation. We recently developed a new model called AI triage for endometriosis patients, where we generated a biodigital twin in order to simulate the unique pathophysiological environment of endometriosis patients. And the idea was that this AI tool will allow us to define the exact window of opportunity for egg freezing before the ovarian response drops below a critical level. And we used 1,000 algorithmic iterations to resolve the conflict between surgical necessity and reproductive preservation in order to determine the chance of a 90% live birth probability threshold. And the model calculates how many additional eggs an endo patient will need compared to a non-endo patient when we consider the long-term damage that can be expected to the ovaries through direct and indirect inflictions because of endometriosis. The calculator provides 3 levels of recommendation: a green zone where you can actually delay fertility preservation even if you plan surgery, a red zone that suggests that surgery will definitely benefit the patient, and a critical zone where it might be futile, it might be too late to freeze eggs. Just to show an example, from this model, we could calculate the number of additional eggs you would need for an endo patient. So you can see this is 12 additional eggs at 35, but 36 additional eggs at the age of 40. Of course, these are all theoretical calculations, but very useful for a patient. And this shows you an example of using this calculator where you can put AMH levels, previous ones and present ones. And this actually allows for a dynamic assessment of the patient's fertility. Here is a QR code for anyone who's interested in looking at that calculator. And actually, if anyone has data that could help us, we are now performing a prospective validation of our data. And of course, also we can use retrospectively collected data, because validation of these models is very important with real-world data. So if you contact us, we'll be very happy to collaborate with this. So to summarize, how can AI predict optimal timing for fertility preservation in endo patients? AI can project the ovarian decline within the next few years. It can estimate future response to ovarian stimulation, and it can predict the number of eggs that will be needed and those that realistically can be obtained. You have to remember that AI cannot override age biology, cannot predict spontaneous conception reliably at present, and cannot replace, of course, individualized counseling. In practical terms, the endo triage algorithm suggests that in younger women with mild disease and normal reserve, you have to individualize the discussion. When there's planned surgery, in most cases you should freeze first eggs, and especially with bilateral and recurrent disease, you should strongly consider freezing. In older patients, at any ovarian surgery is planned, you should strongly consider freezing, but when MH is low, suggesting an ovarian reserve, again, the benefits of actually freezing, or maybe it's too late to freeze, are important. And it's important in every patient who's more than 38, we should do a realistic discussion about the expectations, because it might be too late to do fertility preservation in these patients. So what are our take-home messages? Egg freezing in endometriosis is preventive in younger patients, time-sensitive in older women, strategic around surgery, and AI can definitely help quantify the risk, but clinical wisdom guides timing. Thank you very much, and I hope this information is helpful for our patients and for providing them the best advice. Thank you.
Okay, it's my pleasure to introduce someone that known to everyone in the room here, Professor Farr, one of the founders and organizers of this conference, a pioneer and leading authority in minimally invasive surgical treatment of both malignant and benign GYN pathologies. Dr. Farr is known as one of the best endometriosis specialists in the world. He's the medical director of Nezhat Surgery for Gynecology Oncology and practices both on the Upper East Side of Manhattan and on Long Island. Dr. Farr's Nezhat's expertise lies in treating ovarian, uterine, and cervical cancers, and he specializes in severe and multi-organ endometriosis, pelvic masses, ovarian cysts, uterine fibroids, fistulas, and congenital anomalies. He is a board-certified GYN oncologist and is a clinical professor of OB/GYN at Weill Cornell Medical Center and the director of the Division and Fellowship of Minimally Invasive Gynecologic Surgery and Robotics at NYU Langone Hospital on Long Island. By establishing the Minimally Invasive Surgery Division and Fellowship at 3 hospitals, Dr. Nezhat has provided innumerable training opportunities for fellows, residents, medical students, and national and international visiting physicians. He was among the first to perform, publish, and teach laparoscopic and robotic surgery in GYN and oncology, and he contributes prolifically to scientific and medical literature, frequently serves as a director of postgraduate courses, and is a regularly invited faculty member at professional societies and congresses. His research, educational endeavors, and professional work have earned him worldwide recognition, and it's been a pleasure to co-manage cases and to operate with him myself. We're going to introduce Farr, is going to give us a talk on pathophysiology of ovarian endometrioma, the role of AI in diagnosis and management, and how to maximize ovarian reserve.
So, Stephen, thank you very much. I did not write this. That is AI. I don't know. My assistant together, so I have innocent. Stephen,
It's all
thank you very
true.
much.
It's all true.
So, after previous speaker, my thought makes it easier. So I just want to give you some practical points to take it home. Regarding the physiology of the ovarian endometrioma, this is something that my brother and I have been practicing for more than 30 years. And I give you a summary of it, and hopefully you could take it something home. So the bottom line, you all know about endometriosis. One thing differentiate endometrioma compared to peritoneal, superficial, or deep endometriosis is that large endometrioma is only seen on the ovaries. And why is that? This endometriosis is a fibrotic, progressive disease. Why we see large endometrioma on the ovaries? So, the superficial endometriosis you can see here, and next to this is the corpus luteum. These are two related, and I will tell you why. So these are large endometrioma. Bilateral endometrioma, we call kissing ovaries. It is not unusual. You see them, they are attached to each other. You lift them up, both of them are ruptured. Frequently you see it. So historically, how does endometrioma people suggested? The anatomist Ferreira, he suggested that the blood from the uterus goes to the in the ovaries and goes endometrioma. Samson, as you all know, the John Samson, the petrochemical administration pioneer, suggested that the cyst on the ovary, which is corpus luteum, ruptures, and then the blood from the fallopian tube goes to the ovary and causes endometrioma. And then Samson was somehow correct, and I will explain to you why. Why he found out this, why he suggested this theory, because he did a section of certain endometrioma, and he found that some of them had corpus luteum, and he saw, and some of them they didn't have corpus luteum. And he thought that endometriomas, when they are young, they are corpus luteum, later on, they don't have corpus luteum. Chernowski and Norris, and later on Gazelle and Pouchet, they said that he's some sort of Mullerian with a pelagia on the ovarian surface of the ovary that could cause endometrioma. This theory did not take off later on. In 1992, we prospectively reviewed pathology of more than 300 of the ovarian endometrioma, and our pathologists asked them to section. And we came up with this theory that endometrioma are two types. And this is the bottom line of my message. We published it in 1992 in the Journal of Robotic Medicine, and last year we published the pathophysiology and clinical implication of this ovarian endometrioma formation in Green Journal. And I really encourage you to read this, because you could take a lot of these messages to your home in management of your patient. So we call it type 1 endometrioma, and that type 1 endometrioma are small, usually less than 3 or 4 centimeters. These endometriomas are real endometriomas. They are coming from the cortex of the ovary, invaginate to the stroma of the ovaries. And these endometriomas, when you want to remove them, they will not come out easily. You have to remove them in pieces. And these are real endometriomas, rarely becoming large. And when you put them under the microscope, all of them have stroma or epithelium, and these are endometriomas that never respond to any hormonal therapy. But majority of the other endometriomas are combination of the corpus luteum, and that has been invaded by the superficial endometriosis. Endometriosis is in the cortex, and this endometriosis gradually, if it is not treated, invades the capsule of the corpus luteum, and as time passes and it is not treated, causes scar tissue attached to the pelvic sidewall. This implant moves in two directions. Moves one way towards the lining of the corpus luteum, and the other way goes towards the pelvic sidewall. That is the areas that when you see them, when you lift them up and you feel and you rupture, it comes across that you have ruptured them, but it is not you. It is the way that this endometrioma has before. So, how do you, if you have this theory, keep in mind, and the earlier speakers explained to you how to manage endometrioma, what kind of effect would have on infertility, on the other things. So, what do you want to treat them? These are the example you could see. This is the type 1 endometrioma here, and these are the type 2 endometriomas are attached to each other and always attached to the posterior cul-de-sac. So, type 1 endometrioma, I told you, you want to remove them. You put a pitressin and to between the ovarian cortex and the ovarian stroma to decrease the vascularity of the tissue. You don't have to use electricity, as Dr. Seidman and Dr. Giudice mentioned that you don't want to use electricity to damage the ovary, and you have to only remove this fibrotic area. If you get to the right plane, there is no need to use electrical surgery. You could use some hemostatic agent, and you are done. When it comes to the large endometrioma, this is the ultrasound that you do. This ultrasound, that's all blood in it, will not tell you where you are. Are you type 1 endometrioma, type 2 endometrioma? We classify them to type A, B, or C based on the progression of the endometrial lesion of the cortex to the cyst wall. If you put the patient on suppressive therapy, and the patient is in this stage, if the patient is in this stage, the hormonal suppressive therapy could stop the ovulation, and because the corpus luteum by itself, if it is not and it is not old, it could go away. If you put the patient on suppressive therapy for a few weeks and you repeat the ultrasound, that endometrioma goes away. But it is it's a fresh corpus luteum. But if you, by any chance, you scope the patient and you see endometriosis like this, these are very easy to take care of. All you have to do, you have to remove this area and drain this area. Maximum, you want to take a biopsy to be sure it's not malignancy. But so endometrioma is very easy to remove. Corpus luteum is the easiest cyst to remove. You all, like our surgeon, you know that corpus luteum is easier to remove. You don't want to remove it. You don't see too many endometrioma in our series that are type 2A. Majority of them are type 2B, that the implant has invaded this part of the cyst. When you separate the ovary from the pelvic sidewall, if you excise this area, and then you inject some pitressin, and this is fresh, easily the cyst wall comes out. Easily. And these are the easiest ones that when you are operating, you will realize easily you could remove endometrioma. You don't have to do any electrosurgery. You are not removing the cortex, as our previous speaker said, that if you remove the ovarian cortex, you are damaging the ovarian reserve. The challenge are this type. These are the cases that when you separate them, sometimes there are multiple areas of the cortex has invaded to this cyst wall. These are the challenges. So your perioperative evaluation, I was mentioned, evaluating the AMH, patient's age, all of them keep in consideration. We always try to put the patient with some sort of suppressive therapy because when you put the patient with suppressive therapy, it prevents ovulation. When the ovary doesn't ovulate, operation on the ovary is easier, doesn't bleed. And then you drain the endometrioma, remove all the peritoneal endometriosis, and you try to remove as much as possible and use different techniques to excise them, or certain area you excise, take a biopsy to be sure it is not a typical endometrioma, and the rest of them you could cautiously ablate with CO2 laser or plasma jet, whatever. And that is the reason there are so many papers published that sometimes ablation of certain endometrioma could be better than excision. We published this paper not too long ago that we looked at a series of the patients that they had endometriosis, and we looked at the incidence of the endometrioma, and we found that out of these 222 patients, that 86 of them they had endometrioma. Majority of the patients in endometrioma, they had a stage 3 or 4 disease. Rarely you see ovarian endometrioma all by itself. So whenever you see endometrioma, it's the tip of the iceberg. And if you believe in that endometriosis, because inflammation, like the Giudice said, and inflammation is the cause of infertility and the pain. So endometrioma is the tip of the iceberg, and we believe endometrioma has to be surgically treated with some hormonal suppressive therapy before. So this is an example of endometrioma that you see. It is a type 2C, and you could see it is attached to the pelvic sidewall. You lift it up, it ruptured, as I mentioned. It is not you, it is the way the endometrioma is formed. And you want to always treat the endometriosis in the pelvic sidewall, as we showed it before, and you will see other people. This endometriosis has to be treated. When it comes to the endometrioma, you mobilize the endometrioma completely from the pelvic sidewall, and now you want to excise the endometrioma. Then the best way is to inject some pitressin in the middle of the endometriosis. Pitressin has two benefits. First of all, it creates the plane for you between the cyst wall and the ovarian stroma. Also decreases the bleeding and then makes the procedure easier for you. So when you make this dissection, then you get at the edge of this cyst wall, and always you will find a plane. Always. No matter what you do, you always will find a plane, and then you do the gentle traction, contact traction, you pull the cyst out. When you take the cyst out, again, you could overlap it. Sometimes we suture them to put the edges together, and we try to, you do not use any electricity because, as I mentioned, it could cause damage to the organ. So, if you keep this one in mind, you will realize that if you put the patient in suppressive therapy in the patient with endometriosis, as long as the patient doesn't ovulate, I promise you, this patient will not form endometrioma. And the literature is full of papers that shows the hormonal suppressive therapy prevents recurrence of endometrioma. So all of my young patients, all of the patients that have endometriosis, I encourage them to put them on suppressive therapy to prevent ovarian endometrioma. Treatment of endometriosis, you cannot prevent endometriosis not to come back, but if you put the patient on hormonal suppressive therapy to prevent ovulation, it will not form endometrioma. On the other side, if you put the patient on ovulation induction and you do not follow it, and the patient has endometriosis and form corpus luteum, some of them could become endometrioma. Thank you very much.
We're going to have the Q&A session now, so could the speakers who are present join Dr. Nezhat up here. If anyone has questions, just come up to the microphone if they have one in the audience. While they're coming, I'll get it started. I'll have one for Dr. Giudice. Linda, I'll get it started with a question for you. So given the likelihood of this inflammatory effect on the endometrium, why do you think it is that in large databases of ART, we don't see a dramatic reduction in pregnancy rates in patients with endometriosis?
So, when we say patients with endometriosis, we consider it as a very broad category. And there are so many different phenotypes. I don't know that we have identified through whatever database a particular group that does have a severe form that would compromise implantation pregnancy.
Do you think would you think that there could be a subset where it's an endometrial effect? And because we've all seen these patients individually, but overall it's not in the whole group, so maybe it's a different phenotype.
Yes, to that, but also we don't follow them for pregnancy outcome. And so there's a big disconnect between getting pregnant, staying pregnant, and then 8 months later or sooner, the preterm birth or other complications. So I think that's why a huge amount of data, I think, is needed for us to be able to identify subtypes.
Thank you. We have a question.
Thank you. It was very nice talks. I also have a question for Dr. Judy. So you mentioned that in the UCSF studies, there have been a lot of data accumulated suggesting the comorbidities. And there are many conversations earlier today talking about the contribution of immune responses in the disease and infertility. So does the comorbidity, I assume there will be comorbidity within autoimmune conditions, and these patients probably receive treatment. Are these data giving you any hint about what portion of medications will have an impact in endometriosis as well?
So that's a great question. We have thought about that. So our group, Dr. Tomiko Oskotsky, did an analysis looking at simvastatin, which is one of the drugs that we identified by drug repurposing on some of the endometriosis cells, the utopic endometrium. And what she found, and this is just a correlation, it's not a cause and effect, but she found that those patients who had been on simvastatin had a lower risk of diagnosis of endometriosis compared to those who had not. So, and simvastatin, as you know, is an anti-cholesterol drug, cholesterol-lowering drug, but it also is an anti-inflammatory. So there's a way to mine those data. I didn't mention, and I didn't go through even a few of the 660 comorbidities, but autoimmune disorders is certainly there in a variety, if I heard your question
Yes.
properly.
Thank you.
Thank you all for all the wonderful talks. My question's generally to the panel of infertility specialists. The infertility endometriosis patients are generally shared patients between, MIS surgeons and fertility specialists. And sometimes we encounter them first as surgeons. Sometimes, they're referred from their fertility specialists. And I think one question that always comes up, or maybe something to debate, is the order in which to do things, whether surgery first or trying IVF first. So I'm just curious to hear the REI take on this from most current data.
Yes, this is the question. I mean, the last 10 years in every international congress, everywhere you have the debate between surgery first or IVF first. I think, to my opinion, the answer is really very individualized medicine. It depends on the patient, age of the patient, the reason of infertility. But basically, one sentence comes to my mind always, and this is the question of pain. So if you have a patient who's suffering from pain and the quality of life is suffering, in these cases, for me, the surgery is the first step. But if the deep infiltrating endometriosis, endometrioma, then maybe before performing the surgery, getting eggs as much as possible so that we don't have to be careful about, anxious about the decrease of AMH afterwards. But if the patient doesn't have any pain, maybe the first step would be the IVF. This is my opinion.
Yes.
How can you know the answer to this question without having follow-up data during pregnancy?
Once again, please.
How can we answer this question when we don't have follow-up in the pregnancies? Follow either after IVF or after surgery. We don't have this long-term pregnancy outcome. So how can we answer this question? Can we?
The question was not that. The question was before the patient gets pregnant.
Right.
You're talking about the symptoms during the pregnancy.
Right.
So I don't understand your question, sorry. The question was to go for surgery first or IVF first in an infertile patient before she gets pregnant. You're talking about the symptoms during the pregnancy. I don't know if I don't have a pregnant patient.
Tony, I think the moral point was if patient has endometrioma, should we do the surgery first or refer to REI to do egg retrieval? Because one of the concerns about the surgery is decreases the ovarian reserve. Like Paul and I are working the same area, have been working together, and we actually have published paper together and some other REIs. This is something that I learned, and I'm sure Stephen agree with me. As that Nouri mentioned, it has to be completely individualized. And I'm surprised some societies, they write guidelines. As Nouri mentioned pelvic pain. Pain is very subjective. What I do in my practice, as I mentioned in our data, the patient endometrioma is the tip of the iceberg. It could have retrovaginal endometriosis. Some of them could have a ureter restriction. I saw one of them last week. Dr. Radha Saeed referred her to me. She has bad endometriosis, not too much pain. And then she has ureter obstruction and she has bilateral endometrioma. She's 33-year-old. So I referred the patient to REI to see if she's a candidate to have egg retrieval. Still, I couldn't give more opinion about this.
I think part of the real world challenge here is that one, endometriomas decrease AMH themselves separate of surgery, but not all surgeons are created equally. Anyone doing IVF has unfortunately seen people who've gone for surgery for endometriomas and ended up virtually, if not overtly, menopausal. So as the woman crosses into her 30s and later, and the egg reserve is lower, Seidman's lecture was talking about trying to individualize and can we predict what's the rate of having ovarian failure? Because the only thing worse than doing an egg retrieval and not getting the best eggs that you could have is having surgery that loses the ability to get eggs at all. And so I think, we want some middle ground where we want to try and retrieve eggs and preserve them if we can, and then go to surgery if needed in the high-risk person. But there will be people where the egg quality is so compromised that they need the surgery, and that's that individualization, in the era of which would cause the most harm. The loss of eggs entirely is completely, irreversible. And there's also some of these patients, the endometriomas are so bad that they go to retrieval, they end up with infections and horrible complications. So that's that kind of individualization that, I get upset when I see centers where no one has surgery or everyone has surgery. And that this is the challenge we have.
May I just say, I think I can say one sentence in which we all agree. These cases, they are not for only IVF specialists or endometriosis. I think it should be a real good cooperation and trust. That means these difficult cases, we always talk with the endometriosis specialists, and then together with the patients, we decide together what to do. These are complicated cases for fertility, for endometriosis. So not only one field, not only one person, but a group of specialists.
From a public health standpoint, I think it's important that as California is trying to equate endometriosis with cancer for egg preservation, all these, too often the woman who's not trying to get pregnant right now, the conversation of preserving eggs or preserving embryos when they have endometriomas and their AMH is going down isn't had early enough. And I think it's important that we have those conversations.
I want to add one more thing that when you do the ultrasound or MRI and you see the endometrioma, always be careful there is no nodule in that ovary.
How many do we have now?
That's right, at least 3 or 4. That the patient will follow by the REI, the ultrasound, egg retrieval, and when you go back, you could see there's a nodule in that endometrioma. And then finally, students get out and call and say, Farr, I don't know why these people are stimulating this ovary. You go there and say, cancer.
Call and say, Farr, I have another ovarian cancer I found.
So again, looking at the endometrioma is diagnosed by the ultrasound or MRI. So first, we should there is no nodule. If there's a nodule, it has to go for surgery first. And then after that, as we discussed, you have to individualize. So, yes.
Hi, I'm a patient, and thank you for organizing this. I love to see passion for this type of disease. I had a history of working with patients with IPF, and I think that simulation and biosimilars of that nature is very important. However, I'm curious how you're training the future of medicine on these types of technologies. Do you find it concerning that there's a lack of data? And then whenever we do talk about the lack of data, there's the expectation that we could simulate data, for instance, if we don't have enough. Do you find this as a problem to create models, or do you think that this is going to help the future of medicine? Thank you.
That is the reason we formed the society. That is the reason that you are here. And thank you very much for your comment. That's very, very useful. Dr. Giudice has been working with Cameron and me when I was in Stanford, Sina. We have more than accumulation of 100 years of experience. And we have seen, unfortunately, not some progress, not a lot. And that was the reason we formed this society and also Endomarch 15 years ago to increase the awareness of the society about this disease. And right people like you as a patient to come here, and also other physicians that you are here, they are going to learn, they are going to not only to themselves bring ideas and hopefully with the AI technology that nobody agreed that Nouri mentioned, 30 years from now, definitely, maybe less than, yeah, we are in different situation.
My surgeon went to UCSF, and I'm 1 year postdoc and doing really well. Thank you.
Thank you. Thank you very much. I think you need time for the break. You know break? Thank you very much. This is an outstanding group of speakers. You can see those of you. Many of you are physicians or medicine, but some of you are patients and actually may have no knowledge of who these people are. Really, every one of the people in this program is incredibly accomplished nationally and internationally. So you are getting the benefits of all of them. As you can see, the program is intact, impacted with so many lectures. I will look to see what we can cut off. The only body that I dared to cover was my own lecture. As you can see, I took my lecture off, and some of you have come and asked me, why can you read your lecture? So we have come with a remedy, several requests. Please, those of you who are here, we have the name of the registrant, you have it on your app. We have had more than, we stopped it at 300 because it was 250, we increased it 200 and 300. But you can see, unfortunately, lots of people come and leave or don't stay. And that is unfair to speakers like these gentlemen and ladies who have come and have prepared for you. I appreciate it if you ask your friends that they are here, at least come to the meeting later today and also hopefully tomorrow and Saturday, because that would be unfair for the sponsors and for people who have done this, because the speakers are great. Now, to make it easier for you, please, when it's going to be ready soon, the break, we are not going to give you a regular break. Is it ready, Zoya? We are going to have several of the speakers that are unfortunately couldn't make it. So we are going to do their presentation with a video, and this is on the program, the chest, endo, and AI, and also some other aspects. It's going to be playing, so we will make up for the time, otherwise everything would be later and later. So those of you who want to go ahead, and please go ahead, take your break, it's not fair to you. While you are out, please ask your friends or people who are not here to come back. And also tomorrow, I promise you, I will find the time to give my presentation, because many of you came and you wanted to listen, because that would be unfair to you either. So please go ahead, play the next presentation, which is going to be about thoracic endometriosis. Yes. Thoracic endometriosis, Dr. Wang in the talk.
I understand. It's about Dr. Tulandi and Dr. Sina is going to be played, and Dr. Wang is going to be after that. Okay? Dr. Wang is here. So, but it's too tired for you to sit down. So please go ahead and play the next video. It's going to be with Dr. Tulandi and then Dr. Sina. It's all going to be about AI, Tulandi and AI. Those of you who are patient or you don't want to listen about thoracic, or not Dr. Wang is going to present it. He is here, and that's another great speaker. And Dr. Tulandi had also a speech. He's going to be by video, and also Dr. Sinai is going to be by video, and Dr. Louise King is going to be by video, and to make up the time. And if you want to take a break, go ahead and please outside have your coffee and tea and come back. So let's go ahead and play the next video.
I'm Dr. Tulandi. I'm a professor and chair of obstetrics and gynecology at McGill University. I would like to thank Cameron, Farr, and Sina for inviting me. Unfortunately, I could not attend in person due to unforeseen circumstances.
Presenting the slides.
I was assigned to give a talk on entwined conditions, a complex relationship between PCOS and endometriosis.
I don't know, or do you have slides? Yes.
This is where I work at the Real University on the left-hand side, and on the right-hand side is the Real University Center, where my office is. This is my disclosure. I'm the editor chief for gynecology and obstetrics investigation, and I'm a contributor to UpToDate. Polycystic ovaries and endometriosis are common gynecologic disorders, each affecting up to 10% of women of reproductive age. Traditionally, they are considered as distinct conditions with separate pathophysiology. Recent evidence, however, suggests that alteration in microbiota may play a role in both conditions. Microbiota is a microorganism in a specific environment, for example, in the gut. Disruption in microbiota, or called dysbiosis, can promote low-grade inflammation, hormonal imbalance, and immune dysregulation, a condition that are found in both polycystic ovaries and endometriosis. In normal condition, microbiota, especially gut microbiome, which is a collection of genome from microbiota, plays a critical role in regulating metabolic homeostasis, immune function, and steroid hormone metabolism. One key component is estrobolome, which is a collection of gut microbiome genes. Estrobolome is capable of metabolizing estrogen. So on this picture, you can see estrobolome, and the enzyme, one of the enzymes which is important is beta-glucuronidase. So in the normal condition, the estrobolome metabolized the estrogen, and only a small amount of estrogen will be resorbed and recirculated. So large amounts are excreted outside the body. So estrobolome plays a role in estrogen metabolism. In pathological conditions, disruption in microbial system or dysbiosis is associated with hormonal imbalance, inflammation, and immune dysregulation. Again, both are found in PCOS and endometriosis. Again, here we look, the estrobolome plays a role in estrogen metabolism. In this condition, in these two conditions, most estrogen are reabsorbed and recirculated. So more estrogen in the circulation. And we know that estrogen is related to endometriosis. Just a few words about microbiota and microbiome. Microbiome refers to collection of genomes from all the microorganisms in the environment. Microbiota refers to microorganisms that are found within a specific environment. For example, in the gut. So it could be viruses, it could be bacteria, it could be fungi. How about PCOS? There are evidence that in PCOS there is reduced gut microbial diversity and composition. Dysbiosis is associated with insulin resistance, hyperandrogenism, and inflammation. The inflammation might contribute to ovarian dysfunction and follicular growth. I'll show you in another slide. But here, hyperinsulinemia, oocyte development are impaired. So again, in PCOS, we can see the dysbiosis of gut microbiota. We'll just go all the way down. Here, there is activation of the immune system and inflammation, stimulation to the pancreas. The pancreas will produce more insulin, hyperinsulinemia, and hyperandrogenemia. So it seems like there is a possible link between PCOS and endometriosis. It is via microbiota-mediated pathways. Those two conditions share mechanisms: dysbiosis, immune dysregulation, chronic inflammation, and steroid hormone metabolism. Of interest, in preeclampsia, there is also complex interaction between microbiota and chronic inflammation. Just look at the left panel. In preeclampsia, here again, microbiota here, that is dysbiosis, causing systemic inflammation and stimulation to the heart and to the kidney, causing high blood pressure and proteinuria, and preeclampsia developed. Why we are interested in preeclampsia? Because clinically, we have done a few studies, and we have done it for several years, and we found that there is an association between endometriosis and preeclampsia. We published it about 3 years ago. We recently published another one at the bottom here. Again, association between preeclampsia and endometriosis. We also found that endometriosis is associated with vascular disease, such as Raynaud syndrome, migraine, atherosclerosis. Others have also found that endometriosis is associated with coronary heart disease. And we also found that polycystic ovaries and endometriosis are associated with venous thromboembolism. This is an endometriosis meeting, so let me just mention that we found that, and others as well, of course, that endometriosis is a chronic inflammatory systemic disease. So it's not a local disease only. The chronic inflammation mediates a variety of diseases, including cardiovascular disease. I mentioned about the association with other vascular disease. So these are conditions that affect vascular endothelium. Endometriosis itself has been associated with endothelial dysfunction related to chronic inflammation. The vascular endothelial dysfunction promotes angiogenesis and subsequently further growth of endometriosis. This is our study looking at the association between polycystic ovaries, endometriosis, deep vein thrombophlebitis, and pulmonary embolism. And we found that endometriosis and PCO are related. This is PCOS without endometriosis. We can see the adjusted odds ratio of developing DVT and pulmonary embolism is about 2-fold. So there is a significant association between PCOS and DVT and PE. Here also we found PCOS without endometriosis and endometriosis without PCO. In young females, both of them are associated about 2-3-fold risk of DVT and PE, so endometriosis and PCO. The relationship between endometriosis without PCO is age dependent. We can see the red numbers. This is twofold, onefold, and this is less. However, in PCOS only without endometriosis, the association is still twofold, regardless of the age. So endometriosis has age-dependent association with venous thromboembolism and pulmonary embolism. Whether this association is due to common pathophysiology or confounding factors remains unclear. So we talk about microbiota. There are factors altering gut microbiota, factors that we cannot do anything about it, such as age, ethnicity, and genetics. And there are factors that we can modify, such as probiotics, hormones, diet, stress, hygiene, alcohol, and smoking. This is another study that shows an association between migraine and endometriosis. Again, similar to our study, our previous study, and polycystic ovarian syndrome. In their study, in those with endometriosis, the prevalence of migraine reached up to 44.7%, fivefold. Females with migraine had a higher prevalence of endometriosis, again supporting our previous report. The association between polycystic ovaries and migraine in their study is not quite significant. So I conclude that both PCOS and endometriosis are associated with low-grade inflammation, immune dysregulation, and altered steroidogenesis, which may represent shared pathophysiologic pathways. Which pathway? It seems like it is microbiota-mediated pathways. Further studies are needed. Maybe we can alter the microbiota by diet, decreased smoking, alcohol, and stress. And maybe we might be able to decrease endometriosis or the symptoms of endometriosis, as well as polycystic ovarian syndrome. And thank you for your attention.
Good morning, everyone. I'm Sina Saadati from Amir Kabir University of Technology, which is also known as Tehran Polytechnic. It's a pleasure to share with you our recent works on artificial intelligence-driven endometriosis surgery, in which we explore how AI technology can reliably support and enhance surgical procedures. In this presentation, I'll walk you through the key findings and their significance. Additional details and full methodological discussions can be found in our recent publications in robotic surgery and machine learning with applications. I would also like to thank Dr. Kamran Nezhat and the organizing committee for the invitation. I will begin by exploring the emerging role and transformative potential of artificial intelligence in endometriosis surgery. From there, I will address the key challenges that make automation in this domain particularly demanding. I will then outline our contributions to advancing artificial intelligence-driven surgical innovation before concluding with future research directions that may shape the next generation of clinical practice. Artificial intelligence has transformed many aspects of modern life. We use tools such as ChatGPT, and we've seen AI accelerate drug discovery, improve road safety through autonomous driving technologies, and enhance clinical workflows, from early cancer detection to identifying neurological disorders, such as Parkinson's disease. But what about surgery? In this presentation, we will discuss whether AI technology can meaningfully support or even automate parts of surgical procedures. In the first place, it's important to consider why applying AI to surgery could be valuable. There are several reasons why applying AI technology to surgery is promising. Surgical procedures are complex, highly skill dependent, and often physically demanding. Even experienced surgeons face challenges such as fatigue and cognitive overload. These limitations stem from the biological nature of human performance. Surgeons need rest and nutrition. They can focus on only one operation at a time, and their accuracy and speed can fluctuate, especially under fatigue or negative mood. The limitations don't stop there. Consider an expert surgeon who has accumulated extensive experience and knowledge through numerous surgical procedures. If that surgeon decides to emigrate, much of that expertise becomes unavailable to patients and colleagues in the original country. The same loss occurs when highly skilled surgeons retire. In contrast, AI systems can operate consistently and without exhaustion, making them valuable operators in the surgical environment. Compared to humans, they can be significantly faster, more accurate, and fatigue resistant. They are capable of automating repetitive tasks, such as instrument manipulation or organ retraction, with high precision and speed. And because they are fundamentally software-based systems, they can be easily replicated, globally distributed, and deployed. As an example, imagine that surgical procedures were automated using AI technology. In this case, the system can accumulate experience from surgeries performed around the world, creating a vast and continuously growing pool of knowledge. This would make the system increasingly reliable over time. Moreover, this expertise could be distributed with a level of availability far beyond what is possible with human surgeons. Consequently, reliable AI systems have strong potential to enhance and eventually automate procedures such as endometriosis surgery. Developing an AI system to automate endometriosis surgery is a highly challenging objective, largely because of the critical importance of reliability. In automated surgical settings, even a minor error can cause significant harm to the patient and may have life-altering consequences. One of the key factors determining the reliability of intelligent decision-making systems is accuracy. Higher accuracy means that a larger proportion of the system's decisions on the previously unseen new cases are correct. Although numerous powerful AI models exist, including a wide range of artificial neural network architectures, only a small subset can achieve the high level of accuracy required for surgical applications. Therefore, identifying efficient architectures that maximize accuracy remains a significant challenge and requires extensive research. This involves careful data engineering, which is essential for developing reliable machine learning models, as well as evaluating a variety of architectures to understand their behavior. It also requires identifying the causes of low accuracy so that they can be addressed and eliminated. Interpretability is another critical factor influencing the reliability of AI systems, especially those that are based on deep learning models. It refers to the ability to understand and explain how the different components of a system contribute to its final decision. Advanced AI models, such as deep neural networks, contain millions or even billions of parameters, making it extremely difficult to analyze how each part behaves during the inference process. Consequently, many studies focus primarily on accuracy in test cases and overlook interpretability. However, understanding the internal behavior of the model is essential because there may be certain parameters or inactive components that might be hidden during evaluation and become active in rare or unforeseen situations, potentially leading to unexpected errors in real surgical environments. Another important factor in AI algorithms is robustness. Robustness refers to the system's ability to maintain accuracy and reliability even when the input data contains noise or distortions. For example, Consider a computer vision model that must determine whether an image contains a car. The input image might be blurred, for instance, if the camera lens is fogged or partially occluded by an object between the camera and the car. In more critical scenarios, an attacker might deliberately introduce structured noise to mislead the system. Now imagine such an attack occurring during a surgical procedure on a high-profile patient. It is essential that the AI system remains robust under these conditions and continues to make correct decisions. Having discussed the motivations and key challenges in automating endometriosis surgery, I will now present our contributions to addressing these issues. The automation of endometriosis surgery can be examined from two complementary perspectives: the surgical perspective and the developmental perspective. To address both, we conducted two research projects that focus on building reliable AI systems for surgical automation and overcoming the developmental challenges associated with such advanced applications. In the following, I will present the main findings from these two recent studies. In one of our recent articles, we introduced a reliable approach for automating endometriosis surgery. The work is published in the Journal of Robotic Surgery and is titled Revolutionizing Endometriosis Treatment: Automated Surgical Operation Through Artificial Intelligence and Robotic Vision. In this work, we propose a framework designed to advance the computerization of superficial endometriosis surgery. At the core of this framework is an algorithm that guides a robotic system in performing automated surgical tasks. To support this algorithm, reliable semantic segmentation models are developed. These models enable the robotic system to analyze intraoperative images in order to detect and localize key anatomical structures, such as the uterus and ovaries, as well as endometriosis lesions. To enhance the robustness of the segmentation models, a novel data engineering technique is introduced. This technique is subsequently employed to train and develop ensemble frameworks capable of accurately localizing organs and lesions, thereby facilitating the automation of endometriosis surgery. The proposed algorithm for fully automated endometriosis surgery integrates advanced and reliable computer vision systems with anatomical and surgical knowledge. This algorithm enables the robotic platform to perform key surgical tasks, including organ examination, lesion detection, and treatment. Because the algorithm relies on computer vision, superficial endometriosis lesions are categorized into three classes, including uterine, ovarian, and peritoneal endometriosis. For each category, an independent computer vision model is designed to detect the corresponding lesions within an image. This categorization is grounded in visual characteristics and substantially enhances both the accuracy and interpretability of the models. From a computational perspective, it is essential to clarify how input visual signals are processed to generate the final decision. Thus, models tailored to category-specific patterns demonstrate higher interpretability and reliability than a single monolithic black box system. Semantic segmentation models, which constitute essential components of the algorithm, extract informative patterns from datasets and then use these patterns to analyze previously unseen cases in the future. These models are used to localize the organs and lesions in the surgical images. It is therefore crucial that the datasets contain rich and relevant visual information while excluding unrelated or misleading signals. It is important because informative datasets enable the models to achieve high accuracy, whereas noisy or poorly curated datasets can lead to misinterpretation of signals and degraded performance in the future. For endometriosis lesion detection, a novel data augmentation technique is proposed. In this approach, lesions are repositioned across the host organ in multiple ways. For instance, the lesions are moved across the ovary, as can be seen in these images. As another example, lesions from one patient can be transferred onto the organ of another patient. Our findings indicate that such transformations substantially increase the robustness of computer vision models to variations in the shape, appearance, and spatial location of endometriosis lesions. This augmentation strategy can be implemented using advanced AI methods, such as generative adversarial networks, as well as sophisticated photographic editing techniques. In our research, the second approach was used due to its high computational efficiency. The datasets enriched by the proposed data engineering technique are then utilized to train and develop ensemble frameworks to detect and localize endometriosis lesions during surgery. For this purpose, various deep neural networks with diverse architectures are developed and investigated. Those with higher accuracy are then used to construct an ensemble framework. An ensemble framework functions like a committee where multiple experts analyze the same problem from different perspectives. Consequently, the produced decision by an ensemble framework is more reliable than a single model. Our findings show that the proposed method is reliable and can be used to automate endometriosis surgery. While a minimum accuracy of 50% is considered acceptable in many segmentation studies, our system achieves an accuracy of more than 90%. The system is also interpretable, as each module is designed for a specific task. It also demonstrates high robustness because it incorporates the proposed data engineering technique. The ensemble structure of the framework further enhances robustness, since models with different architectures that are trained on the same dataset tend to learn similar underlying patterns while capturing different types of noise. Regarding the robustness of deep learning models, I also invite you to read another one of our papers, in which signals from human walking are analyzed. In this paper, as well, we show how ensemble neural networks can demonstrate higher robustness. The work is titled Cloud and IoT-based Smart Agent-Driven Simulation of Human Gait for Detecting Muscle Disorder. So we have seen how the proposed algorithm can automate endometriosis surgery. But developing this algorithm requires several arduous developmental tasks. To create segmentation models, we must provide the computer with a large number of masked images. Image annotation, however, is a labor-intensive process, as it demands a significant amount of time, energy, and concentration from human experts. This is why many valuable surgical images and videos remain unused, even though they could serve as rich sources of patterns for computer vision applications. For this reason, computers must be able to learn these patterns without any help or supervision from human experts. In computer science, this is known as unsupervised learning. There are unsupervised learning approaches for some machine learning models, but not for semantic segmentation. Therefore, in another research project, we have proposed an unsupervised learning method for semantic segmentation, which is published in a paper titled Unsupervised Deep Learning for Semantic Segmentation Using Laparoscopic Videos, a self-detection and self-learning approach in the Journal of Machine Learning with Applications. The challenge is that for each target element, a large number of images and video frames must be masked and annotated. A higher number of annotated images provides more information for computer vision models and allows them to achieve higher accuracy and reliability. Here is an example of a single image in which the ovary is masked. This pair of image and mask, along with other pairs highlighting the ovary, helps the computer extract patterns to detect and segment the ovary as the target element, even in new and unseen images in the future. However, annotation remains a significant challenge for human experts. This challenge can be remedied by utilizing an unsupervised learning method for image and video segmentation. In our work, a deep learning model is guided through a step-by-step process in which the model learns new patterns. detects its incorrectly learned patterns and improves them, and gradually expands its knowledge. Since the learning and improvement are performed by the computer itself, this method is referred to as self-learning. Self-learning is an AI technique that can be applied in various domains. In our paper, we show how it can be used to detect and segment objects such as cars and airplanes, as well as anatomical elements such as organs or endometriosis lesions. We also show that the self-learning method is powerful and robust. Even in surgical videos with visual noise, the computer can still detect the element of interest with high accuracy. These noises include intense light reconfigurations, geometric organ deformation when they are grasped by instruments, color similarity across diverse organs, fog camera lenses, and strong shadows. Here is an example. As you can see, the ovary is being moved. It is geometrically deformed, and there are significant light reconfigurations. However, the computer still detects and localizes the target organ accurately. The video is generated by the proposed self-learning method, in which no data annotation is performed by humans. As a result, the self-learning method can be used to automatically annotate huge surgical videos and datasets, and consequently, offer a rich source of patterns for developing reliable AI applications. We also have additional research that I believe is worth highlighting. One example comes from our work on a computational geometry problem known as the convex hull. At first glance, this might seem far removed from surgical image processing. However, geometric algorithms play a central role in many computer vision systems. For instance, this work is used directly in the self-learning method, enabling the system to recognize its own errors and refine its understanding. In another study, we explored how convolutional neural networks can be used to model aspects of the human visual cortex. This line of research helps us better understand how these models interpret visual information. Those insights, in turn, guide us in designing computer vision systems with greater reliability, which is an essential requirement for surgical applications. While successful contributions have been made to automate endometriosis surgery, there are still several challenges that must be investigated. The stochastic nature of surgery should be studied in order to provide computer vision applications with higher reliability. The motions of the robotic arms also need deeper investigation, which requires further multidisciplinary research in robotics, surgery, and artificial intelligence. The proposed algorithm can also be integrated into ultrasound imaging to enhance the accuracy.
Okay. This is an outstanding work by Dr. Saadati. Those of you who were lucky and you were smart, intelligent to be here, this is incredible. He is one of my students. We published a couple of papers together, and you saw really, he gave you the roadmap how we are going to, what I have been telling you, that the future would be very different. You are going to be a group of people that you heard it the first, that endometriosis would be, so this was one of the best presentations that you could have ever heard. Unfortunately, he couldn't come here because of the war in the Middle East and the issue, but I hope I am going to present this again for you. You have to listen to it over and over to understand, because I am sure very smart, you are smart to be here. Share it with those people who are interested. That is what we are going to be doing, and that's what I have been working on. And when I tell you that the future is there, I have proven it in the past that I have done it before with my team, my brothers, and my other members of my team, and we are going to do it again. One question that came up, again, very, very respectfully to everybody, and and I agree with the panel before that the care of the patient with endometriomas and endometriosis should be individualized. Surgery first or IVF first. And again, the panel very nicely addressed it. The answer is individualized care. Unfortunately, we and my team sees many patients with endometriomas who have been inflamed, infected. They get in the hospital for a 3 to 4 weeks period. You can ask my former fellows who have been here, and one of the fellows this year that a patient that was in the Stanford hospital for 3 weeks because endometriomas got infected following IVF by a fantastic, extremely experienced IVF group. So this is one of the risks. So and also Dr. Farr says, endometriomas are the tip of the iceberg. If those of you who are patient, and some of them, they came into the break and asked me this question, if the younger patient, the surgeon is very experienced, younger patient in their 20s, 30s, when they are not close to the 40 and earlier, and if the sperm factor is good, still this patient, they have a very good chance of getting pregnant if surgery is done in a very experienced group. 20 years ago, actually exactly 20 in 2005, 21 years ago with Dr. Giudice, we did a group of patients that we published in Infertility and Sterility. They were blinded to me. They sent me a group of patients that I did surgery on them, and the other group, they kept doing IVF. The group that they were match control, the surgery, the patient, the results were definitely significantly better. To this day, recently, Dr. Nezhat published again another paper and matched, and it's almost the same result. So surgery, if it is done by a very good hand, not to make things worse, especially in the younger group of patients, in my experience, is better. But the surgeon has to be experienced. That's all I wanted to say. Now, I will introduce you again to the next group of the panel for the presenter. So please go ahead, and then we hopefully will make up some more time. But please try to stay on time.
Thank you. So thank you, and we start with this session a little bit late. I am Caterina Exagustos. I am an expert in Rome for ultrasound and endometriosis, and my co-chair. After everyone, I'm Kate Lawrenson. I do a lot of endometriosis cell and molecular biology at UT Health in San Antonio. So the session is about endometriosis and adenomyosis in extragenital parts, and it will start the patient. Is she here? Stephanie Jones.
Hello, my name is Stephanie Jones. I currently reside in Scottsdale, Arizona. Next up, you'll meet my AI twin to help tell my patient's story.
I began experiencing excruciating menstrual pain by age 16. Pain that would leave me bedridden for days, missing school and later work. A weekend period felt like winning the lottery. At least I wouldn't have to miss an activity or explain my absence. For years, I was told this pain was normal. It'll get better after you have kids. You're too young for it to be anything serious. Let's just increase your ibuprofen to 800 milligrams. At 19, after years of pain and repeated dismissals, I was diagnosed with endometriosis and underwent my first laparoscopic surgery with laser. That began a cycle. Every 3 to 4 years, another surgery to manage the pain. I started continuous birth control to suppress menstruation and buy more time between interventions. In my late 30s, early 40s, I made the decision to pursue motherhood through IVF. My OBGYN and I prepped with another laparoscopy. What we discovered during surgery shocked her and me. Both of my fallopian tubes were blocked and severely damaged. We later proceeded with tubal ligation, followed by IVF. 5 healthy embryos were implanted. Hope was high, but none survived. I made the difficult and definitive decision not to pursue additional rounds. It required a moment of clarity, not of defeat. A couple of years later, the pain returned. When I consulted with a top surgeon, she reviewed my history and said, "Stephanie, you've been through this a number of times. It's your decision. Do you want to have surgery again?" I had come for a solution, not a philosophical question. But at that time, I chose to live with the pain. A year later, I returned. This time, I was more prepared, and she came with a new mindset. She sat with me, reviewed new research, and said, "I'm confident in what I do, but I can't guarantee surgery will improve your lower abdominal pain. I don't know him personally, but Dr. Nezhat specializes in complex abdominal pain. I think it's worth seeing him." That referral changed everything. Dr. Nezhat diagnosed me with adenomyosis, a condition that had gone undetected despite years of treatment. He clearly laid out options, and I chose surgery. What he found was extensive. Endometrial tissue had grown not just around reproductive organs, but also around my bowels, bladder, urethra, and had the potential of closing in on my aorta if left untreated. The surgical notes used the word difficult more than once. I had never imagined the level of internal impact. For the first time, I wasn't just managing pain. I was recovering and healing with a better quality of life ahead. To medical professionals, I wish more of my earlier providers had explored beyond traditional frameworks and recognized that chronic pain and infertility should never be normalized. A broader lens, deeper curiosity, and a willingness to challenge what's typical could have meaningfully changed my trajectory much sooner. To anyone still seeking answers, your health is not just a women's issue, it's your life. Keep asking questions. Refuse to be minimized or unheard. Relief may not come quickly, but sometimes it does come. And when it does, it's worth everything it took to get there.
So next, I'm delighted to introduce Dr. Wang. So Dr. Wang serves as a director of MIGS and the Endometriosis and Fibroid Clinic at Bronx Healthcare System in South Bronx, New York. Dr. Wang's clinical expertise centers on minimally invasive surgical management of complex gynecologic conditions, including fibroids, endometriosis, adenomyosis, polyps, and ovarian masses. He has particular expertise in the treatment of advanced endometriosis with a focus on alleviating chronic pelvic pain and preserving fertility. Complementing his clinical work, Dr. Wang is actively involved in lots of training and mentoring, and also translational and basic science research with a primary focus on endometriosis and uterine fibroids. He's published more than 50 peer-reviewed articles and remains dedicated to advancing the field through ongoing research and innovation. So please welcome Dr. Wang.
Good afternoon. Thank you, everybody. Thank you for the introduction. And I'm Dr. Wang from Bronx Care in Bronx, New York. So, sorry. Okay, good. First of all, I want to take this moment to thank Dr. Nezhat giving me this great opportunity. I'm very grateful. Second, by no means I'm the expert in this field. I have done maybe like 5 or 6 surgeries on the diaphragm, and my experience is very limited. But once Dr. Nezhat gave me this task, I did quite a lot of literature study. So today, the main talk is to share what I have learned for the past couple of months with you. I know we have Dr. Ferreira, Dr. Tulandi is not here, but they published extensively on this subject, and they are true experts. If I have any mistake, please correct me. The thoracic endometriosis syndrome is the endometriosis in the thoracic cavity and give us a broad spectrum clinical manifestations, and 70% of patients present as catamenial pneumothorax. And of course, some people even has no catamenial pneumothorax, they still have the endometriosis. Endometriosis for this disease can be found in the pleural cavity, the bronchopulmonary site, and the diaphragm. For the timeline, in 1938, Dr. Swartz reported the lung endometriosis, followed other doctors report the endometriosis at different site, but it was not until 1992, Dr. Cameron Nezhat performed the first laparoscopic endometriosis surgery on the diaphragm. This pioneer work inspired more surgeons to work on this field. And in 2009, Dr. Nezhat published the first paper about 4 cases, their experience of laparoscopic surgery and the thoracic surgery, meaning put like a group of surgeons together to treat this disease. And in 2014, they published another 25 cases. So this pioneer work really laid the ground for even now for the surgical principle to treat this thoracic endometriosis. For my literature study, I think after this Dr. Nezhat's work, our really the European colleagues took over the lead. They perform more endometrial surgery on the thoracic cavity, and you can see in 2020, and the multiple large centers in Europe, they published more data on this subject. What do we know after 30 years of research? We know thoracic endometriosis is probably the most common endometriosis outside of the pelvic. And about 70% of patient has no symptoms. 50 to 90% of patient may have the pelvic endometriosis in time, and the diagnosis age pretty late, about 35 years old, and then 90% of the endometriosis on the right side. The standard diagnosis is thoracic surgeon, not from us. They do a thoracoscopy and find the endometriosis. And we know this disease most likely is underdiagnosed because of the missed history, the poor imaging study, and we probably cannot identify the disease because the inexperience. And the most important thing is the pathology. So what do we do now? We probably those numbers, they're probably correct, but not exactly precise. We don't know the we don't know the etiology. We do have some theories, but none of them really sounds reasonable. And we don't know the optimal treatment, and therefore we have some data for the follow-up, but we don't have the long-term follow-up after our treatment. How do we did well or not so good? I want to take a moment to talk about the pathology. We know most of us as surgeons, we give the sample to the pathology, we get the report, we think they are good. We think we could name them like a gold standard, but probably it's not like gold. The thoracic endometriosis is different from the pelvic endometriosis. In the pelvic endometriosis, on the slides, you probably can find the stroma cells, the gland cells, and the macrophage. But thoracic endometriosis, mainly the fibroblastulus. And 45% of the sample, actually, you only can see the stromas, but not the gland. If you look for the gland, you probably will misdiagnose the disease. And the recent publications really talk about the markers. We do immunostaining check, ER, PR, CD10, and the PAX8. dramatically increase the diagnosis of thoracic like endometriosis or other endometriosis outside of the pelvic. So next time, if the pathology tell you they didn't find endometriosis, probably not true. So if you look at Dr. Tulandi's paper, and they published a nice paper in 2019 as well, the meta-analysis on their paper, they talk about six like the trials, and they give you the number differently from 39% of diagnosis to 83% of diagnosis. I think one of the reasons may be the sampling, but we cannot underestimate the discrepancy of the pathology protocol from a different institute. That is why all those numbers jump everywhere. The imaging study, of course, most people use MRI, and some of the articles report high accuracy, but in real life, probably not true. We will talk more about the imaging study later. So what's the treatment for this disease? As I say, Dr. Nezhat in 2014 or 2009 already told us this disease cannot be handled by thoracic surgeon, cannot by gynecology, but this is a teamwork. So we have to do the surgery even same time above the diaphragm and below the diaphragm, and we have a very good team of the anesthesiology as well. So from gynecologists, we mainly deal with this disease below the diaphragm. So today I want to focus on our perspective. So this is the diaphragm. A diaphragm is about 1 to 6 millimeter thickening and composed like has the central deep tendons and the muscle. On the surface, there's like a phrenic nerves and phrenic vessels. And of course, there are like 3 hiatus, and the 2 vessels, IVC and aorta, pass through the diaphragm, and also the esophagus past the diaphragm. So this is our anatomy. So Dr. Nezhat displayed the algorithm of the treatment in their 2014 review articles, and this picture I borrowed from Dr. Ferreira's paper talked that if you decide to do the surgery, here's the trocar placement for the gynecologists and the thoracic surgeons. Dr. Ciccaroni described the lesions on the diaphragm based on the size and the thickness. They describe the foci, the nodules, and the plaques. Depends on different lesions. Our surgeons, we can use either ablation or partial resection or full thickness resection and try to deal with this disease in the surgery. So what's the potential complications for this complicated surgery? Not uncommon. We have to mobilize the liver in order to access the deep posterior endometriosis. So we have to understand the structure of the liver. Based on the blood supply, the liver can be divided into 8 sections. And you can see below the liver, on top of the liver, we have the inferior vena cava. We have 3 hepatic veins. And they were in the very small area, so surrounded by 3 ligaments. So this area, the liver, the IVC, is very from multiple organs. Not even most of general surgeons feel comfortable to deal with all those areas. So on top of this, there are multiple variants of the hepatic vein in this area. I can tell you a true story. But between the general surgery PGY1 and OBGYN surgery, I did a 1-year transplant. And one time when I did a procurement with attending, I was dissecting exactly this area, okay? The harmonic area. So I don't know if I poke the hepatic vein or IVC. You can see the blood is like full of the blood. You can imagine how mad my attending was. So he asked me to put my finger on this bleeding, and then he basically dissected the liver by himself. So it's not like without complications. Here's the article talk about what kind of complications we can have even for the most experienced surgeon when they do the liver procurement. This is study for 241 procurement. You can see the liver, the damage is 80, right? Yes. The vessels is about 50 cases. So if we gynecologists want to deal with those, this area, we have to be extremely careful. Another potential complication is the diaphragm. What's on the diaphragm? The nerves. If we look at the nerves, phrenic nerves below the diaphragm, actually what we see is the terminals of the phrenic nerves. Where's the nerve from? Nerve from C3, C4, C5, past the neck, the heart, and enter the diaphragm from the top. So what's the anatomy of the phrenic nerve? I found this very beautiful article from Brazil. They did like a cadaver dissection for 21 phrenic nerves. You can see from the right side, they have, before the nerves enter the diaphragm, they branch. For the right side, there are always 3 branches. From the left side, it can be like 2, 3, 4, 5 branches. Where's the location for those nerves enter the diaphragm? From the right side, it's always in the middle. For the left side, either the middle or the anterior. So the main branch enter the diaphragm very in the center. About 15% of the chance for thoracic surgeons to damage the phrenic nerve during the surgery. What happens if we have the damage of nerves? If it's a terminal, if it's unilateral, probably patient is doing fine. But if a bilateral is a major trunk the nerve, the patient will have the problem like shortness of breath, chest pain, recurrent pneumonia, or the fatigue. So the diagnosis of a nerve injury is basically checking the diaphragm with the X-ray or the ultrasound. The thoracic surgeons can do the nerve reconstruction or the diaphragm pedication. The last one, but not the least, the pneumoperitoneal-induced pneumothorax. You can see like it's not uncommon at all if you do the diaphragm endometriosis, if you do the full thickening resection, you have this pneumothorax for sure. Even you don't do the dissection, and sometimes you still can have the patient, even before you do the dissection, the patient can have this pneumothorax. There's like one article from Brazil, this is Dr. Ferreira, the last one. They report like a two cases of the tension pneumothorax in their surgery. It looks like a very dramatic. So the diagnosis of the pneumothorax, if we didn't see the hole when we do the surgery, it's really hard for the diagnosis. Most of the time, the changes with the very subtle changes be noticed by our anesthesiologist on the other side of the drip. That is why the communication is very important. The experience of the anesthesiologist is also very, very critical. So most of the time, the anesthesiologists find this, they are really have a hard time to ventilate the patient.
1 minute.
Oh, sorry. Oh, okay. So the double lumen is a good idea. So how are we going to minimize the complication? I think first of all, we have to follow the principle. Most of the time, we find the diaphragm endometriosis in the intra-op, but not before the surgery. Dr. Nezhat in 1999 98 say like, you know, if you want to deal with the diaphragm inside of the surgery, during the surgery, you have to be very good surgeon. You have to have the backup. You probably have to talk the patient thoroughly. And the endometriosis maybe are just superficial, not so bad. So follow this principle. Two European group, Dr. Ciccaroni and Dr. Horace Roman, reported their experience. For Dr. Ciccaroni, they treat all of the patients in the surgery when they find endometriosis, but Dr. Horace Roman treat only 60 patients, only when those patients have symptoms. Yes, so should we use a laparoscopic robot? Most people use laparoscopic from previous study. Dr. Horace Roman reported there are 60 cases with robot. They think the robot helped them so much because of the better exposure and the full dissection. So, but I think this is case by case, and our surgeons probably have to use the best way we feel comfortable. The AI. I completely agree. Down the road, maybe AI will help us to do the
Please, can
surgery.
you conclude, because it's really...
Okay, good. So I'm just the last slide. So I think the AI can help us for the diagnosis. For the MRI, we know the MRI sometimes we report a very high sensitivity, but in the real life, I don't think it's really good. So the Ciccaroni report like 16%, and the Roman report about 46%. I think that what AI can help us is like maybe they can read more MRI and generate a program and then shared by everybody. For people from us, like from just practice in a community hospital, we still can send this program, our MRI, they can tell us the patient has diaphragm endometriosis, and we probably can send this patient to the referral center instead of operated by us. Thank you so much. Sorry.
Thank you. Next speaker, it's my pleasure to present to you my friend and colleague, Dr. Carlos Simon, who is a professor of OBGYN at the University of Valencia, and also senior lecturer at Harvard University. He has focused his work on understanding human embryonic implantation during the preconception period. He's renowned for pioneering the discovery of human endometrial receptivity through transcriptomic analysis, further validated by single-cell RNA sequencing, and he's got groundbreaking research, which includes uncovering the role of the endometrial microbiome, leading to the development of molecular diagnostic tools. He's got about an index of 136, 552 peer-reviewed articles, and multiple awards by various scientific societies. Carlos, please.
Thank you, Anthony, for such a nice and large presentation. I want to thank you, the committee and the Nezhat brothers for inviting me here today, and to just champion this initiative, which I think is key to really create the awareness for endometriosis worldwide. If I can have the first slide. Yeah. So I have been, the idea was to present you with this topic, gut microbiome, artificial intelligence. So, and this is what I would like to do in the next 14 minutes. I have no conflict of interest regarding this presentation. In fact, what I'm going to show you is a starting research project that with this feedback, maybe I will continue or not. The learning objective that I would like to bring here to you is basically to appraise what are the, I think that this is the wrong presentation. I update this presentation, but it's okay, I can go for that. So basically what I would like is to appraise the gut microbiome implications in endometriosis, and then to critically evaluate the methodological strengths and limitations, and finally, to identify realistic opportunities that can give us artificial intelligence to stratify the risk of those patients. So if there is something that we all agree, is that endometriosis is a syndrome. And because of that, we need to personalize this situation. And the microbiome come to this angle to give us a different view. We all have the experience that sometimes you give antibiotics to your patients with endometriosis and they improve. Those are anecdotal. There was a big paper in Science Translational about Fusobacterium that finally we couldn't repeat. We also published the fact that we could not repeat the presence of this bacteria as a factor just producing or inducing endometriosis. But the gut microbiome is a different issue. The gut microbiome somehow, this is the biological plausibility of this, which basically goes with the hands that the microbes present in the intestine, which is the most frequent place for the microbiome, those microbiomes, if there is a dysbiosis, they can act as a pro-inflammatory agent, as you will see, and also they have their own estrobolome. They are able to rescue estrogens and make active estrogens back again, the one that has been deactivated by the liver. And of course, they can break the epithelial barrier in the intestine and go to the peritoneal cavity. So with all of this is basically the biological plausibility to consider the gut microbiome of something that will be interesting, associated, or we can find markers for that. But what are the evidence? Can we truly define a gut microbiome in endometriosis? So these are, I just bring you these three papers. The most important one is you have in the middle, is the largest one that has been published. The other one, they are meta-analysis. Conclusion is that there is no consensus whatsoever between those studies. There is not a signature that they can find in the gut microbiome in the feces as related to endometriosis. So because of that, I thought that let's have a conceptual shift here. Just from the signature to the microbiome endotype. It's not the signature, it's what the microbe is doing. And because of that, let's just try to focus on the different endotypes. That could be an inflammation-dominated endotype, or could be a pain-dominant endotype, gastrointestinal comorbidity endotype, hormonal modulated endotype, or nothing else. So the hypothesis that I want to bring in this presentation, which is just to brainstorm with you, is at what extent the microbiome differences may be due to endotype specific rather than species or just genus specific or signature specific. So how can artificial intelligence can really help us with that? I skip this because I go directly to this. Artificial intelligence nowadays can just bring us control the data that is being produced, which is a very large amount. So they can go from descriptive to predictive, being the data driving. And they are essential for analyzing this high dimensional data as in any other discipline. And they capture complex nonlinear host microbiome interactions that we will never do with our human mind. So with all of this, let's see what has been done using artificial intelligence, but I mean machine learning, not generative artificial intelligence. And there are basically a few papers about that. The first one is this one, which is, you can see the title. This is a case control study, 21 endometriosis patients between 20 controls, and what they do is basically 16S ribosomal RNA, which is the sequencing of the microbes itself, and then they are just trying to get also another classifiers for that. When they go for this and they compare in peritoneal fluid and they compare in the feces and also in the cervix, in the vaginal or cervical fluid. Okay, to our surprise, the most predictive part they can find in the feces. Peritoneal fluid is not an option. It will not be non-invasive approach. So somehow the message here is the fecal and peritoneal fluid models are the best in order to predict or associate with endometriosis. A different paper using also machine learning, in fact they use random forest model to compare all the data, basically are the same, they have less cases and controls, but the message is exactly the same. The gut microbiome features outperform vaginal microbiome and hormonal markers as they have seen. And the third paper this is a meta-analysis of all the papers, a systematic review. All in all, they have 182 samples, 72 fecal and 130 vaginal from different sets. And the message at the end is this. So by using this meta-analysis of 16S ribosomal RNA, is the fecal but not the vaginal microbial composition that is closer in patients with endometriosis. So this starts to be interesting. However, this is the data of this paper. So they distinguish this differential fecal taxa accurately predicting endometriosis, and this is the meta-analysis. However, all of these papers, they have methodological limitations. And this is the small sample size, as usual. This is what we used to say. And there are a few limitations. The compositional data used rarely, they are rarely addressed with all the different clinical data. The confounders, they are not very well handled, so there could be a lot of confounders in those studies. And this is a rare comparison versus clinical, hormonal, and baseline to quantify this. So there are different situations that can be improved. So I went to learn from the big brothers, which is, in this case, what happens in neuroinflammatory diseases using artificial intelligence. And you can see these three papers published in high impact journals. This is Science Translational, Nature Communications, in which what they try is to go for the prediction of this fecal microbiome for Parkinson's disease, Alzheimer's, and you can see a large number of patients. So those are studies that they are starting to be believable, and in fact, they have already getting incorporated in the field, and they are giving another clue of diagnostic in those cases. So taking all of this in consideration, I just asked ChatGPT to make the experiment of how did you handle this if we consider that in addition to clinical data, we cannot, for the microbial part, understand that microbial is just what I am addressing here, but of course there are many other factors that you all know. How can we do, if we try to do this in a personalized way, considering endotypes rather than species or genus of the microbes? So this is a little complicated, but I will explain you. It's quite easy to follow. So what the ChatGPT is telling me that you have to have a patient entry, and the step one will be the clinical phenotyping, which is obviously what we do. It's just to understand the chart history of the patient, and with that we can create what they call the generate clinical baseline risk score. The clinical baseline risk score. And with that, you really go ahead or not. If you go ahead, you can go to the next step, which is basically go for the gut functional score using stool test, applying to this, in which by simple PCR and by simple metabolomics, you can measure a number of items that I will explain you now when we talk about the patients, in order to get this score. And then you have to put all of the two scores, this multimodal integration, clinical and functional scores, and then you get a diagnostic decision node to move forward. And after that, according to the endotype classification that you have done, whether this is inflammatory, estrobolome, gut-brain axis, or whatever, could be treated differentially to the way that we are treating our patients. And this is the treatment decision node. And finally, the prognostic mode, response to prediction, and so on. Let me just bring to you some examples in the last 3 minutes that I have. This is patient 1. You have the clinical data here in your left hand. And then we talk about just to obtain feces and do just this 16S ribosomal RNA that give us the bacteria plus the functional model. So in this case, you have these 2 bacteria, and there is an increase of the LPS axis by using the functional node, and there is a decrease of butyrate axis. Just for your understanding, the lipopolysaccharide axis is just pushed by the capsule of the bacteria, and they produce systematic inflammation. Butyrate axis means that maintains the gut barrier integrity. So if this getting low, means that this get out. So somehow this patient has, whatever it has of endometriosis, but will be an endotype A, which is inflammatory modulated. And then the treatment should also be focused on these anti-inflammation possibilities. This other patient, when we do the 16S, they give us genus level variation with nothing interesting. But when we do the functional model, then we detect that there is an increase of beta-glucuronidase. Beta-glucuronidase is the enzyme that some bacteria, they have to produce the estrobolome. The estrobolome make possible that these estrogens that has been deconjugated by the liver, they go to the intestine. So those bacteria, they get them back to the circulation because they still make active estrogen. So you have a huge amount of estrogens without knowing this because of the presence of this bacteria. So this is an endotype B, and there is estrobolome driving, and you have to consider seriously to monitor the estrobolome by giving these anti-estrogens or whatever it is, even if you don't find it in blood. Patient 3, similar issue. The 16S doesn't give us anything, but the functional node give us this increase in the kin trypsin ratio, which is related to pain, to the immune activation, and to neuroinflammatory disease. So in this case, in addition to what we do, we have to consider this part, which is the pain that should be also actionable. And patient 4, there is no microbiome whatsoever. So it has been a microbiota neutral and should be treated without any type of issue regarding to that. So what I try to bring here just for our thoughts together is just that this will matter because with this analysis in feces, a simple collection of feces, we can have a descriptive taxonomic non-actionable part, but also we can have a probabilistic endotype-based decision-modifying analysis, and both altogether could refine our decisions, not replace clinical judgment, and of course, not to be applied universally, but this can give us another viewpoint of such a complex process, which is endometriosis. So in conclusion, what I bring here is that the relevance of the gut microbiome in endometriosis, the fact that, as I mentioned to you, there are different axes that can be observed and actionable and in action, and this maybe can give to you a different perspective, and in the future could be considered as an associated diagnosis for that. And I have to tell you that for me is just another piece of paper, another piece of information, but for me is kind of painful because I used to work in the most beautiful organ of the body, which is the uterus, and I start to find some solutions in the place that I mentioned to you, which is not the place that I thought I would find solutions for our beautiful organ, which is the uterus. In fact, when I work with the people that go for the vaginal microbiome, I work in the uterine microbiome. I used to tell them that I work in the penthouse and they are going to the parking. So, but now I cannot use this rationale anymore. So in conclusion, what I try to bring is another piece of mind of that should be incorporated, and artificial intelligence, of course, can give us a lot of responses about that. And just to mention that this is the work of the people working in my foundation. There's one research project on that, and we are in Valencia, and if you want to collaborate, we are always open to make it possible that pathologies affecting the uterus will no longer be an impossible barrier. Thank you very much for your attention.
So we have to go on. I will introduce Professor Ferreira from Porto, Portugal. I know him since he is very, very young, because he was a fellow of Professor Badier and then Professor Kazem, so one of the best surgeons that we have in Europe. And he's now a very excellent surgeon. He had to do a lot of live surgery in every congresses, and also what I like from him that he teach a lot, and this is the role of a professor. Thank you.
Dear colleagues and friends, thank you, Caterina, for the kind introduction. Thank you, the Nezhat family, for the kind invitation. I'm very honored to be here in the United States. I travel from Porto to share with you our experience and knowledge on such an important topic that is bowel endometriosis. We all know that, is it fine? Yes. We all know that is a challenging location of endometriosis. We need specific skills to approach it, to treat it, and to offer our ladies, our patients, the best outcomes. Nowadays, with the technology evolution, with the robotics and with the AI, I really believe that we can improve even more the quality of the surgical care that we offer. So I had the opportunity in my center in Porto to start this robotic program with two different platforms, Intuitive and Medtronic, and also I'm responsible in my university for the artificial intelligence share. So I will share with you our work on this important field. Well, these are the learning objectives of my talk. We know that in endometriosis, many times the anatomy is distorted, is contracted thanks to the inflammatory disease. Robotics brought us several important advantages, benefits in terms of precision, 3D vision, also tremor filter. In endometriosis, artificial intelligence also already started to bring some important information concerning the location of the disease, concerning the mapping of some important structures in the pelvis, like the ureter, like checking the perfusion of the bowel. Also, we know that because it's a challenging surgery, it is associated with the complications, and AI also has been important in recognizing those complications. And when we talk on the bowel complications are, in my point of view, the ones that we have to care most of the time, because they can bring huge morbidity and mortality to those young ladies. Also, in this surgical approach, we have to pay attention to the nerves, to map the nerves, the somatic and autonomic innervation, in order to improve the quality of life of these patients, keeping the function of those nerves that are responsible for the sexual function, the urinary and the digestive function. And again, finally, the integration of the MRI, the CT scan that we do before the procedure in intraoperative view, and this is becoming a reality. I'm really optimistic that it will become used more and more, offering the surgeons safety and also efficiency in the surgical procedures. These are some statements that we are all aware. What is endometriosis? Why is important to go in a multidisciplinary approach, involving the urologists, involving the colorectal surgeons, sometimes the thoracic surgeons. So the multidisciplinary team approach is of paramount importance. Also, again, I tell it to my students every day, anatomy is the pillar of surgery. So there are some important anatomical considerations that we have to take into account in colorectal endometriosis, like the surgical planes. We have to be familiar with the Okabayashi space, with the Latsko space. We have to go medial to the ureter, medial to the inferior hypogastric nerve, very close to the bowel, in order we can approach for example, the rectovaginal disease in a nerve-sparing way. We know that the nerves go lateral to the bowel, so if we find that a vascular space, I also can say space without nerves, we can be efficient, we can be safe, and we can spare the nerves in that location, because what matters to excise the endometriosis if we impair the nerves, if we impair the sexual function of these ladies, or the bowel function, or the urinary function. That is not the aim. The aim is to improve the quality of life. The aim is to excise this disease that is benign and affects women of reproductive age, so we have to be very prudent. Well, the preoperative study is crucial in the process. MRI, ultrasound gives us a lot of information concerning the location of the disease. Ultrasound, we have here Ekaterina, she is a worldwide reference on ultrasound, is taking a more and more important role on the process. But still, I think the MRI, the neurography, MRI neurography to map the nerves has still an important role in order to understand before the surgery the relationship between the nerves and the other important structures like the vessels, like the ureter, but also the relationship between the nerves and the nodule, the location of the disease. Because our aim is to excise the nodule, excise the disease, but preserve the nerves. We have done a lot of work on that, ultrasound versus MRI. We have published the MRI of endometriosis. Again, there is this colonoscopy. There is a controversy if it is important or not before the surgery, and there are also already some works, and our hospital in Porto is working on that, on the application of AI to identify those lesions in the bowel mucosa, if they are related or not to endometriosis. And this makes a very important, I should say, information to decide if we go for resection, segmental or discoid resection, if the disease is transmural and if it reaches the mucosa. Minimal invasive surgery, laparoscopy, and robotics brought us this beautiful vision, magnified, high resolution. Also, the CO2 allows us to work better in the retroperitoneal space and to operate bowel endometriosis and deep endometriosis. The retroperitoneal approach is of paramount importance, so we can have this pneumodissection that is very helpful. Some remarks concerning the surgical techniques for colorectal endometriosis, and we are aware of this, the shaving, if we have superficial disease infiltrating the serosa and even the muscularis, we can do the shaving. with different approaches. I will show you with electrosurgery, with cold scissors, with ultrasonic, or even with laser. If the disease is transmural, if it reaches the mucosa, we can go for discoid, and this is something that we have to work together with the colorectal surgeon, because unfortunately still many of them are not open to this approach, and this approach is much more conservative, more economical in comparison with the segmental resection, and we are doing more and more the discoid resection. And finally, if we have a big nodule, if we have multifocal diseases, if the nodule is far from the anal verge, we really need to go for the segmental resection. But we know that it is associated with more morbidity after the procedure. The distance from anal verge is an important information that we can get before the procedure with MRI, with ultrasound, or even with fibrosigmoidoscopy or colonoscopy. The size of the nodule, also the percentage of the circumference of the bowel that is infiltrated by the disease. If we have more than 50%, we should think about segmental resection. If less than 50%, we can go for a discoid resection. And again, the preoperative mapping. So let's go for surgery. And we know that in robotics and in laparoscopy, the first entry is crucial to offer safety to our patients. We know that more than 50% of the complications related with laparoscopy happen during this first entry, so we use the level up to approach the abdominal cavity. The extent of the resection, as I said, is dependent on several aspects. We can go for shaving, we can go for discoid, we can go for segmental resection. And in this coronal cut of the bowel, it's clear to see when we go for shaving, for discoid, and for segmental resection. Again, shaving, we can go with monopolar scissors, monopolar hook, short bursts is important. If we stay long with the monopolar energy activation, we can cause a thermal spread, and we don't want it. Now we have the ICG together with artificial intelligence that gives us the information on the perfusion of the tissue. And we know that the healthy bowel that you see on green is well vascularized, and the endometriotic nodule, the fibrotic nodule, is not well vascularized. And this is an important information in our dissection, in our approach to this cleavage plane. This technique from a friend of us from Australia, Danny Shu. I saw him do it by laparoscopy, but also by robotics. He uses the same technique that it is used by endoscopy or colonoscopy to inject the methylene blue diluted solution. In fact, for shaving, I think the robotics brought a very important advantage. Why? Because for shaving, it's the mobilization of the instruments, this wrist 360-degree mobilization allows a more, I should say, precise shaving, precise dissection in our approach to superficial bowel endometriosis. Well, these are the benefits that are stated in the literature: 3D, wrist instrument articulation, tremor filtration technology, improved surgeon ergonomics, shorter hospital stay, and organ preservation. And I like always to see this video of Howard's. This is a Medtronic UGU approach. This is the right inferior hypogastric nerve. And the main advantage, in my opinion, of robotic platform is that you control the vision, you zoom in, you zoom out, but look, the vision is very stable. So you can apply monopolar energy very close to the nerves in short bursts in a very precise way. And this is, I think, one of the main benefits of using robotic platforms. in comparison to laparoscopy. Again, another example, in our center, we do a lot of robotic approach to endometriosis. We follow the walls, opening the parietal spaces, the Okabayashi space, using ICG to map the ureters on both sides. And again, as I said, these articulated arms and instruments allow us to be efficient in our surgical excision approach. The discoid, again, I think this is very gynecological. It was Harry Rich that started with that. I was with him 1 week ago in New York, and we were discussing this, I think, genial idea. We just take the nodule anteriorly or even laterally. We can go with a circular stapler, 31 millimeters. We can use we record this video in Strasbourg with Arnaud Vattier in 2009, and it's very simple. We place the nodule between the anvil and the machine, and then we close it and we excise it. In terms of functional impairment, is much better in comparison to segmental resection. We also do double discoid resections. It's the same. I'm not here. We use a 33 circular stapler. You see that is also used for hemorrhoids, and it works very well. And we can also do a double discoid in different locations. This one is a little bit far from the anal verge, and we go first on this far location, we excise it, and then we go more proximal to that rectovaginal junction. So in the same patient, we did two discoid resections without the morbidity associated with the segmental resection. It's of course of paramount importance, talking on bowel endometriosis, the tests, the safety tests, and we use indocyanine green more and more, intrarectal. You see there is some leakage there, and we reinforce the anastomosis using the barbed suture. Segmental, here we have to keep in mind this picture that I will show you. We have to be conservative. We have to remove only the specimen with the disease, if there is stenosis or if there is this is an approach. You see all the nerves are there, are preserved, the splanchnic nerves, the autonomic sympathetic nerves, and with ICG we also can map the ureteric pathway on both sides. And now with the ICG, we can also check the vascularization of the bowel after the anastomosis and before the anastomosis to tell us where should we transect the bowel. Endometriosis is different from oncology. We don't need to remove large specimens. We have to work very close to the bowel. We don't need big loops. Again, ICG, if we wait 30 seconds after intravenous injection, we see the fluorescence that tells us where we should cut the specimen. This, in fact, brought us safety and less complications for the patients.
1 minute.
If we do segmental resection, it's important to check with all the possibilities available. Transrectal checking, it's interesting to see if there is bleeding or if there is any leakage or any black areas of the fluorescence. Artificial intelligence, again, brought us this power, preoperative MRI segmentation, ultrasound deep learning diagnosis, also checking the ICG. There are some potential complications and risk factors that we have published, and our paper has been very cited and won the prize of ESGE. There is the leakage, there is the fistula, urinary dysfunction, and we are treating young ladies. If there is any suspicious of leakage, we have to go immediately for a second look laparoscopy, and sometimes if we find a leakage, if we find a fistula, we have to do or a ileostomy or a colonoscopy according to the bowel preparation. Again, I want to stress on this, if there is a bowel complication, we have to be very fast. in the reaction. This is the paper that I was speaking about. Early diagnosis is the key. Time is an issue. More time passes, more the risk that the patient dies thanks to sepsis or septic shock. We are now following this Japanese study concerning the anastomosis. We published this study on ghost ileostomy to avoid the ileostomy when we do the anastomosis very low. The LARS is an important complication of segmental resection that is not very spoken. And now with artificial intelligence, I think we can improve. And these are some measures to reduce the risk of the complications. But anyway, I want to highlight that the surgeon experience is crucial in this process. And the strategies to minimize the surgical risk are preoperative mapping, ultrasound, MRI, nerve-sparing dissection, selective urethral stenting or mapping with ICG, ERAS protocol, protective ileostomy. And this was my message concerning bowel endometriosis, the robotics application, and AI integration. Thank you very much for your attention. And I invite you to 16, 18. Thank you very much.
Thank you very much. I think we might have a few questions right at the very end of the session, if time permits. Thank you. So next, I'm delighted to welcome Dr. Deborah Lee to the podium. Dr. Lee is based in Temple, Texas. I'm specialist in OB/GYN with a focus on minimally invasive and endoscopic surgery. She got her medical degree from UT Health Science Center at San Antonio and completed residency at UT in Austin, Dell Medical School. Currently, she practices as a physician at Baylor Scott and White Medical Center, and her area of expertise includes endometriosis, fibroids, hysteroscopy, laparoscopy, and carbon dioxide laser therapy. So please join me in welcoming Dr. Lee.
Well, it's been a wonderful day so far, so I apologize if some of this has kind of already been heard, but we will just reinforce it. But we're going to talk about basically AI now in genitourinary endometriosis. We're going to talk about what AI can bring to treatment and diagnosis. So, urinary tract endometriosis is another name for genitourinary endometriosis. And when we're talking about endometriosis, we've said multiple times today that we know that it's systemic and inflammatory, multi-organ, not just the pelvis. Earlier, we also emphasized that endometriosis can affect fatigue, brain fog, things of that nature. It necessitates multidisciplinary care led by often a gynecologist, but also with our partners, with our team, which can be urologist, gynecology, oncology, it can be urology, CT surgery. When we're talking about urinary tract endometriosis, we're often talking about, When we're talking about urinary tract endometriosis, we're talking about the bladder, ureter, kidney, the urethra. I have not seen endometriosis of the urethra, but we often see it with the bladder and the ureter. I have the privilege of teaching residents and operating with residents, and I often tell them that endometriosis loves the ureter. We often find endometriosis on the ureter, and certainly we find it often on the bladder. Symptoms of urinary tract endometriosis can be urinary frequency, it can be urgency, pain, blood in the urine, pain with intercourse, certainly a cyclic nature to these symptoms. However, of note with endometriosis, you can have no urinary tract symptoms and be affected by urinary tract endometriosis. For instance, in the picture I have here is actually one of my cases from, I think, a week ago. The patient really didn't report any symptoms related to endometriosis, but she did have fibroids and desired pregnancy. And so looking at her right pelvic sidewall, we can see she does have some endometriosis along her ureter, and true to form, it's kind of the tip of the iceberg lesion, where once you reflected the peritoneum, you could see that the lesion was perhaps growing into the ureter. Of course, we know that this is similar to endometriosis in general. We can often see patients that have no pain, no symptoms of endometriosis. You can move forward with surgery for perhaps another indication and see that patients have a lot of endometriosis. So prevalence of urinary tract endometriosis, it remains unclear given that many times it can be asymptomatic. However, in studies, we found it to be anywhere from 0.3 to 12%. Most often seen in the bladder, 85%, ureter 10%, although it feels like more when you're operating. And then in women with deep endometriosis, we can find urinary tract endometriosis in 20 to 50% of these patients. In fact, the urinary system is the second most common site of extrapelvic endometriosis. So one complication that we often watch out for is hydroureter. And it's very gratifying to be in a case and to kind of free up the ureter and to see it in front of you kind of returning to baseline. And you've kind of helped that patient given the risk for silent loss of the kidney. We know that endometriosis can go all the way through to the mucosa of the bladder, and certainly you can see there in the other picture how it's kind of progressing through the anterior reflection. So there are two phenotypes of urinary tract endometriosis: superficial endometriosis and deep endometriosis. We know the etiologies of endometriosis. We know that they're unclear. We have thoughts on, how we think endometriosis spreads. However, something unique to urinary tract endometriosis is that we can have basically bladder endometriosis and kind of endometriosis related to women with a history of C-sections. Here, the pictures kind of show you the blister lesions with the superficial endometriosis, and then you can see that really not pretty for the patients, but it looks like kind of a medallion lesion, and that lesion did grow around the ureter and actually into the pelvic sidewall. So that was considered a deep endometriosis lesion. Luckily, it didn't grow through the ureter, and we were able to excise that lesion. So what complications are we worried about? We're worried about obstruction of the ureter. This can lead to hydroureter and ureteronephrosis, basically by compression or transmural implantation. Many times you do need surgical correction. You need excision, ureterolysis, or resection of the ureteral tissue with reanastomosis with the psoas hitch or a Boari flap. And as we know, some women can suffer silent loss of the kidney. So there's an IVP and a CT scan kind of showing you some findings of a kidney that is in need of help. So robotic surgery in endometriosis, should we do robotic surgery? Is conventional laparoscopy better? What is better? The takeaway is that from this study, robotic surgery is safe and has good outcomes compared to conventional laparoscopy. This was a systematic review. One interesting study, I believe it was actually a Dr. Nezhat study, showed that you can have slightly longer operating times with higher BMI. And I think that was the study that did stratify according to BMI, but otherwise they did not see any perioperative or postoperative complications, blood loss, conversion to laparotomy, and then across studies, there was heterogeneity in operating time, but overall did not find increased operating time. So we know there are benefits for robotic surgery for urinary tract endometriosis. Certainly, I think prior presentations have talked about the 3D vision, the instrumental degrees of freedom, or kind of the different ways that you can move your instruments, whether it be translational, rotational, the endo wrist, and precision. There's the ease of suturing, which can be helpful for a multi-specialty team. So, it's easier to suture on the bladder, perhaps easier to do a ureteral reanastomosis and things of that nature. It also kind of works well when you're teaching residents with the dual console. I think many of the surgeons here would probably agree that you want to talk to your team, and it's really the comfort of the surgeons. How can we best take care of the patient? How can we keep the patient safe? How can we accomplish our goals and keep the patient safe? So for instance, at my institution, I have a CT consultant who does not use the robotic platform, but it hasn't affected us at all. We're still able to do our cases together. We find a way. He will do conventional laparoscopy, we'll do robot, or we'll both do laparoscopy. colorectal surgery, urology, they do prefer the robotic platform, and then our GYN oncologists are flexible. They're comfortable with either. So now AI. So what has AI brought to urinary tract endometriosis? Well, we know there are some challenges with endometriosis in that we are underfunded, so research is underfunded, although I know, we are working on that. We lack easily accessible, easily obtainable, highly accurate screening tests, although, the tide is turning there. Treatment is widely variable, and while individualized treatment algorithms are important, still there's a lot of variability in how patients are treated and who's treating the patients, and there is no cure. So AI has emerged as a promising tool to help patients and address the complexities of endometriosis. So I thought this slide was interesting in looking at over time how the number of studies are increasing over time. I would argue that that is a positive finding. We also look at basically what topics are being, when you kind of look to see what studies are being published on endometriosis in AI, you see the biomarkers, image analysis, surgical interventions, and these are all positive things that will help us take care of our patients. Diagnostic delay is a huge problem. So, the biomarkers are important. The imaging analysis is important, not only for diagnosis, but also for preoperative planning. And then we should definitely make sure that we use any of the adjuncts that we can. So one of the adjuncts that we are seeing with AI and endometriosis is basically things to help us with urinary tract endometriosis. So things to identify the ureter, certainly in frozen pelvis cases, and where we really can't identify proper anatomy, and in deep endometriosis cases where you're kind of really trying to identify your ureters, and potentially also in high BMI cases. So loss of tactile feedback is something that we know with robotics, although I think it might be to some degree corrected with the DD5. But possible solution is the fluorescence imaging with the ICG. So this study I thought was interesting because it was looking at AI and real-time imaging, identifying the ureter in colorectal surgery. So basically they used a deep learning platform and overlaid images, and were able to basically in real-time performance, it took 71 milliseconds for ureteral identification. And so that's kind of a proof of concept that in terms of urinary tract endometriosis, that is something that can help us. If you're real time, trying to move through your case, that is a real way that AI can help us if you don't have, ICG. So in this study, it is helpful to know that the deep learning algorithms are very helpful in several of the kind of goals that we have for endometriosis, whether that is, helping us with cases that have, very challenging anatomy, so the pelvic adhesive disease cases, the identification of ovarian endometriomas, which I know is not relevant to this talk, but in other cases, and then real-time lesion identification, and then, like we said, identifying the ureters. I thought this graphic was kind of helpful because it kind of rounds it out. You're looking at your preoperative management. You're looking at kind of getting a patient a diagnosis with your AI tools. So you have your biomarkers, you have your preoperative imaging studies. So with your AI tools, maybe they help you see that you have a deep endometriosis lesion on the bladder. So then perhaps you might get an MRI, and then from that MRI, that might prompt you to have your urology team, if needed, be present. So that is somehow that AI would help us. Then in terms of during intraoperatively, you have your AI tools that can help you intraoperatively with lesion identification. Perhaps there was an AI tool that talked about being able to define deep endometriosis margins that could be very helpful for your bladder, so that you might be prepared for resecting part of the bladder, and being able to have that conversation with the patient preoperatively, and having the right tools in the room and people in the room. So I thought this was interesting because these are different deep learning collections of data that complement one another. So these are basically complementary collections of data that YOLO, RadNet, and UNet are all basically complementary, overlying one another in order to help identify lesions in real time during surgery. I thought Glenda was very clever because that is also, specific to gynecologic surgery, is basically images and videos from laparoscopic surgery, and again, working on lesion classification, and bringing it back to urinary tract endometriosis. Again, if you identify that it's overlying the ureter, it can help you with your cases. So risk reduction is everything, right? We want to accomplish our goals and keep our patients safe. So AI can help us, in preoperative imaging with our multidisciplinary team involvement. Things that we do outside of AI, we often do hydrodissection, vasopressin, as was discussed earlier, ICG if you need it. And AI will hopefully have a major impact towards helping us. So what's next? So we hope that there's a lot next. We hope that we have better treatment for our patients. We hope that we have basically better opportunities to take better care of our patients in a more efficient way. Obviously shortening operative time, and helping our patients to be comfortable moving into surgery, knowing what the expectations would be. Certainly, as a surgeon, I want to know as much as I can what personalized guidance I need for my patients. Which patients should I take for surgery? Which patients that I take for surgery will do well, which patients would do well with medical management, and which medicines. And I think AI can help us with those things. And that's it.
Thank you for being time. Thank you. Next speaker is Dr. Michael Louise. He's going to talk to us about complications, minimally invasive robotic surgery. Dr. Louise is a board-certified OBGYN practicing in Brooklyn, New York, completed his residency in OBGYN at New York Methodist Hospital, and fellowship in minimally invasive surgery at Stanford. Currently is Vice Chief of Gynecology and Director of Minimal Invasive Gynecologic Surgery at New York Presbyterian, and specializes in both management of endometriosis and fibroids with a focus on resident education and safety.
Good afternoon, everyone. And the topic, again, it's almost like our order's a little bit out, but I'm going to go back a little bit because I'm going to talk sort of much all the complications and all the different types of surgeries that we have and how we can avoid it. My mentor, who is Dr. Nezhat, who I did my fellowship with, he had said to me, perfection is a habit. And I do find that is really important to teach our students and our residents, because doing the same thing all the time is what's going to prevent complications, prevent injuries. But now also with the use of AI, we're going to see major changes going forward. These are just a list of my disclosures. So most of you had these two guys or other pilots fly over to Las Vegas. And what's really happening is they're going through their checklist. Right? We do our OR checklist. We go through our steps in terms of preparing what we're going to do. And prevention is key. And most of the time, prevention is really more important than the management itself. And like I said, once you're going through with your anesthesiologist, with the rest of your team, you're going to decrease the likelihood of running into something that's unexpected. Or if you do anticipate things, having the right equipment in the room, knowing who's on staff, who's on backup. These are some of the things that you want to have in place. And we know that MIS surgery or minimal invasive surgery, there's improved recovery, but it doesn't eliminate the risk. We're doing a lot more complex surgeries these days, And there's still complications that are running between 2 to 6% of the cases. And most of them are actually happening on that initial entry point. So the major risks are vascular injuries, bowel injuries, and also in terms of that that insufflation of the abdomen, so preperitoneal insufflation. And we know that 50%, and as some of our other colleagues already mentioned, 50% of the injuries actually happen with that initial entry. What are these risk factors? And most of the times it's prior surgery, and a lot of people get scared. As soon as they know that they've had a prior surgery, they're worried about adhesions around the umbilicus. But it really depends on the type of surgery they had. If most of the patients you've had have either a C-section or something, or a laparoscopy, the likelihood of adhesions around the umbilicus is very low. But things that you should be asking are, did they have a hernia repair? Have they had a history of a endometrioma that had ruptured, or they had a TOA? I mean, these are things that you need to be asking yourself in terms of preparation, because the likelihood of adhesions may be high, but it's where those adhesions are likely to occur. And you have to understand or know your patient in terms of their size. Someone who's going to be very obese, your entry is going to be a little bit different than someone who's extremely thin. And this is just, again, a video showing that it doesn't matter. You can still be going in through your entry point at the umbilicus and still actually create an injury, even if you're doing the same thing every time. So some of the prevention strategies, of course, knowing your anatomy and knowing some of the alternative sites that you can enter, Palmer's point, which is in the left upper quadrant, but then other techniques that you may use in terms of using the optical trocar, which in that previous film was showing that even using that, you may still get an injury. There's other techniques, which is sort of the open approach, where you're dissecting each layer going in. And then there's also the varus needle. So knowing those different techniques, but I still say, and I tell my residents, or I tell like some of the fellows that we work with, doing the same thing every single time is going to minimize your chance of injury, or at the same time, recognizing if you feel something's not right. And so the bowel injuries are usually one of the most feared injuries to have during laparoscopy. And usually it's twofold. Either you're going to notice something right away, and then that's usually upon that entry point, and you're like, okay, now I've just added another hour to my case because now I've got to call in somebody else. But it's most of the times when it's not recognized. So understanding, again, preparing for your surgery, understanding if you have a case of severe endometriosis, getting that right pre-op management. And even if you're taking down scar tissue, or you're bringing down something, say, for instance, the omentum, which is the padding around the intestines, you may want to take a look from a different report or a different trocar to make sure that you're not going through part of the intestine. So like as has been shown in the other videos, endometriosis involving the ureter, involving the bowel, these put potential for having major complications. And it's that delayed diagnosis, that injury that you didn't see happen in the operating room, but patient shows up in the emergency room or is calling your office the next day with a fever or feeling unwell, or the pain is not getting better. This is also, I know we have also a lot of patients in the room, patients who are asking questions about, or afraid to have surgery because worried about certain things, but understanding what are the risks involved with surgery, and also knowing or preparing what's going to happen, or what should I know to expect, or ask questions after surgery, also very important. You should always be getting better after surgery. And it would always be, ingrained with me as well. If the patient calls with anything, even if their toes hurting, get them on the phone, just speak with them to find out that they're feeling better since the surgery. This is also like in terms of, a delayed injury or delayed management of something involving the intestines. This is actually a trocar site hernia, where the patient was complaining of post-operative pain and came into the emergency room, had left-sided pain, and had an immediate CAT scan that was done and identified that she had actually a portion of the bowel that was through one of the trocars. And one of the common things that residents like to do at the end of the case, because patients always say, just please make sure you take all the gas out after my belly, and they start pushing on the stomach after they removed all the trocars, and sometimes that may push it up through one of your incisions. So again, early recognition is key. Injuries to the urinary tract occur about 0.5 to 2% of the times. Again, this may happen with cases of deep infiltrating endometriosis, where you're having to dissect the retroperitoneal space. But if you can't see the ureter, or you can't see because of the disease, you work your way up higher, you go up to the pelvic brim. and you sort of like will go from the known to the unknown, and don't just go after the area where the disease is, And the other thing is also most patients that we operate in as well will have fibroids, and these fibroids will distort the anatomy, push it into the sidewalls as well. So trying again to make sure that you identify your ureters, like it was mentioned before, the use of ICG dye is also helping in terms of identifying the ureter. So, like I mentioned, prevention is key. Knowing or identifying your ureter at the beginning of the case is what's going to help you go forward and being comfortable. So this is one case where we had endometriosis that was noted on the ureter, and again, there was no way around it. This is something that was choking the ureter, and we called in one of our urology colleagues who was able to come in and do a resection. But this case actually was one where the patient had no pain, and this was found incidentally. But being able to identify or having tricks to identify the ureters intraoperatively is what's going to save you from problems or complications that may occur. And vascular injuries is something also obviously that you don't want to incur during the procedure, but a lot of the times they may be visible immediately. So you can have the very rare catastrophic ones where you may hit the aorta or the IVC, but more often you're getting some of the injuries to the anterior abdominal wall. And this may include the inferior epigastric or some of the lateral vessels. And this is a patient who had an injury to the inferior epigastric, that the actual injury had occurred with trocar placement and wasn't recognized initially, and slowly bleeding over time. And eventually had stopped, but after the case, once the patient was back in recovery, and then several days later, had this bruising throughout the entire abdominal wall. And so obviously quick recognition is key. And most times when you have injuries to the anterior abdominal wall, you can put immediate pressure. You may use one of those laparoscopic closure devices like the Carter-Thompson device. And in the extreme emergencies when there's bleeding that can be controlled, obviously never hesitate to do a laparotomy. I know most, again, don't let your ego ruin it in terms of like saying that, no, I'm going to complete this case laparoscopically. You have an injury, you got to treat it right away. And then other tricks in terms of using transillumination. Again, it may be harder on the more obese patients, but transilluminating the anterior abdominal wall, mapping out your vessels, and even trying to track the inferior epigastric from the intra-abdominally as well, which you can. Thermal injuries is also something that may not be recognized initially. And there's usually 3 different types of thermal injuries that happen during the procedures. We're using a lot more energy, also sometimes, again, if in a laparoscopic case, you're having 2 different surgeons that are operating at the same time, one who's controlling the camera, one who's not. And so that puts an increased risk of causing a thermal injury. But you can have 3 types, which is usually an insulation failure in terms of the device that's sort of like the coating of the device itself. One common thing that I usually see is we have these vessel sealers that will desiccate and cut vessels, and the ones that articulate, sometimes the residents will, I won't only blame the resident, tendings too, it'll be articulated, and when they pull it out of the trocar without being back to straight, that insulation or the outer coating may come off and exposing some of it. So it can be very dangerous. Capacitive coupling is also another way where energy is transferred across through to the tissue, or direct thermal spread. You have instruments that you may not recognize that are close to each other or touching, and that other instrument is touching the bowel or touching a vessel, and that may lead to an injury as well. And these are cases where it's usually often delayed presentation. So prevention is obviously visualized activation. It's for those who have sat on a robot on the console, you're using your feet while using your hands at the same time, and you're toggling between instruments. I've done it before where I've actually accidentally hit the wrong arm while, being close to the bowel or close to a major vessel. And it's always important to make sure that all of your instruments are in view at all times. Obviously, don't be using the higher power settings, but try to use the lower power settings to get the same effect, and avoid prolonged activation on the instruments. So again, a little bit of repetitive in terms of what our prior colleagues had said, but robotic surgery is really unique in terms of some of the risks that involved as well. There is, for some of the older generation robots, there's that lack of tactile feedback, but we're seeing on the new DB5 that opinion may change a little bit. You also may have collision of the arms, where some of the instrumentation, again, may have caused some coupling. And then also port complications. Some of the trocar is a little bit larger. Again, you may have a injury to the anterior abdominal wall that you may not recognize until the end of the procedure. And then, of course, for those who are just starting on the robot, the learning curve may be a little bit longer. But when I compare in terms of my learning curve and how it's changed my use of the robot versus the straight stick laparoscopy for excision of endometriosis, I do find, again, improved vision, the stability of the robot, and what I'll mention also in terms of education. But the role of AI and technology in terms of how it's going to help decrease our complications is what's changing a lot. I mean, when I, growing up, played hockey, at the end of the games, all their games were videotaped. What would you do? You go over your game. You see where you can improve. You see how you could, what strategies you can use to beat the team next time. And it's the same thing in terms of some of the technology that's being used now to help improve our performance in the operating room. And this is one of the companies, actually, I remember they were here, I think they were at the last year's event, called Theodore, and they used AI-guided anatomy recognition to really use real-time complication rates. It's pretty much surgical video analytics, and it's really helping us decrease both our complications and identifying and preventing injuries in the future as well. And this was a study at JMIG, I think it was from December of 2025, with the use of AI intelligence during a robotic-assisted laparoscopic hysterectomy. And again, using images or using any other imaging to overlay our anatomy to identify, certain key structures. So whether it was in the middle picture, like identifying the ureter, or even just some of the tissue that maybe you're able to cut, or areas near the bladder. I mean, this is key. This is going to help a lot in terms of pretty much as you're starting to roll out and do your surgery, especially with the younger generation of residents, identifying key structures and anatomy and sort of identifying everything to, again, minimize your risk of injury. And the potential impact, again, as we were mentioning over and over, is that recognition of complications, but it really, in terms of improved training, when I compare in terms of my training from residency, which was 17 years ago or almost 20 years ago, it's really changed in terms of what was the see one, do one, teach one, to now, again, more and more simulation has happened over the past decade. But now in terms of the robotic simulation and now with the use of AI, it has really made it a lot safer and easier, and also more efficient in the operating as well. I mean, we could really, the fact that most ORs in our institution, every single robot has 2 consoles. So the ease and the ability for me to sit down with my resident, stop in the middle of the case, go over the images, identify key figures, and then afterwards work on them with the simulator and then get feedback in terms of how they're doing. This is really what's impacting their training. And I know one of the biggest things is us discussing, like, how are we training the next generation? And it goes to, there is minimal training of endometriosis in medical school and in residency, and it's only going to be through these larger academic centers that we're seeing more of these sort of endometriosis centers. But it's really key to having the right tools with us. And now with the use of all these different technologies to identify lesions, to help perform safer surgery with simulation, this is going to make it easier to have more surgeons operating. So just the take-home points again, complications are preventable. Entry is, again, our highest risk, so doing the same thing every time and understanding when there may be an issue is key. Early recognition saves lives, and again, technology and AI is going to improve safety in the future. Thank you.
The question will be probably at the end if we have time, because we are very late. Sorry. So it's my honor also to introduce Dr. Louise King. She will address about the systemic barriers to collaboration and care in women health. And She's assistant professor in obstetrics and gynecology at Harvard Medical School. She completed her doctors in Tulandi and law school. And then she was also a fellow by Professor Nezhat. And her areas of interest in medical ethics focus on questions and informed decision making. She's here. There's a video.
Make it start with face.
Okay, fine. Then we have time for questions. Ah, she has a video. Okay, thank you.
Hi, my name is Louise King. I'm so sorry I can't be there with you today. I'm taking care of my daughter who needs my help. Thank you for your understanding. I am a reproductive bioethicist. I'm a surgical specialist in complex benign gynecology. I'm the associate director of ethics at the Brigham and Women's Hospital. I'm a program director for a fellowship in MIGS, or complex benign gynecology at Brigham and Women's and Mass General. I'm really happy to be here to talk about how we can achieve better collaboration in care and women's health. Here are my disclosures. None of them are related to the topic. I want to talk to you about ethics and how we could be informed by ethics, or sometimes what's called humanism, to create better care models for endometriosis and women's health care. A lot of us think that we take a Hippocratic oath. We don't. Hippocrates would have had us keep all of our medical knowledge secret. He also said that we couldn't do surgery. I will not use the knife, not even verily on sufferers from stone, which were bladder stones, the first surgeries performed. So certainly our current ethics and professional ethos does not match Hippocrates. We should not say that we take a Hippocratic oath. We do not. We actually take the Lasagna oath. This is Louis Lasagna. He was the first at the NIH to write one of the modern oaths of medicine, which focuses on our duty to our patients, our duty of care and compassion, of bringing our own conscience to bear in the care that we provide, and to be humble and careful and to follow evidence, et cetera, et cetera. He was a truly amazing clinician and researcher and humanist. In terms of what is humanism, what is ethics from a philosophical standpoint, it generally rejects theism, so it's not based in religion. It's rational, it favors autonomy, and in more modern times, it's associated with social progressiveness and egalitarianism. But when you think about it in the medical sense, we all know of the Arnold Gold Foundation Awards of providing kind, safe, and trustworthy care, or trying to provide humanistic medicine or values-based medicine that we embody in our teaching models and in narrative medicine, which is a form of ethics communication around stories of our patients and of ourselves, and in empowering our patients in shared decision-making models. This is a wonderful colorectal surgeon who's also a fantastic ethicist and created the Center for Values, Ethics, and Law in Medicine at the University of Sydney. And he would describe our humanistic model as a values-based model, reminding clinicians of the sustaining values that underpin the whole of the health endeavor. And those values include acceptance of the value of the individual human life and quantity and quality, I'd add, as defined by the person, and of the importance to both individuals and communities of human security and flourishing. So what does this all mean? Our ethics demand that we provide, or that we engage in, conscientious provision of evidence-based care. So our conscience drives our provision of medical care. It is evidence-based. It's interventions, procedures known to provide benefit to our patients. And then we can constantly change these iterations of how we're delivering the care so that we ensure that we are achieving the best outcomes possible. And it's governed by our professional ethics. So why do we struggle to achieve that in endometriosis care and in other areas of women's health care? And in the context of the problems that we see in our in the provision of women's healthcare, what are our professional duties to create solutions, our professional duties of care? Well, one thing to recognize is how our discipline came to be, and it's a problematic history. In the 20s and 30s, and between the two past world wars, obstetrical practice became more surgical, and obstetricians moved in where there were paucity of surgeons after the First World War and during deployment for the Second, to take over gynecologic surgery. The rationales behind it were not well thought out. They had to do with basically the idea of if we can operate in the pelvis for obstetrics, we could operate in it for gynecology, and also some misogynistic overtones with some people saying the true woman's physician was actually, other than her husband, the most important man in her life. Women's healthcare, their reproductive, healthcare related to their reproduction, related to surgery of gynecologic organs, is being siloed off from other areas of care in a way that resulted in worse outcomes. In the 40s, the majority of gynecologic surgery was still performed by general surgeons, but when performed by gynecologists, there were huge complaints being levied that the ureteral injuries and genitourinary fistulas were increasing in incidence. And this is true today. I mean, our discipline of gynecologic surgeons accounts for the majority of ureteral injuries, and to a much greater incidence or extent than other disciplines that operate in the pelvis. We've been able to show in a paper published in JMIGS that with fellowship training in high volume surgery, we actually have less ureteral injury than other disciplines that operate near the ureter. So there are solutions to this, but we certainly haven't created them yet in our discipline, which at the time in the 1940s was still a 3-year program with 18 months of obstetrics and 18 months of gynecology. As we'll get to in a minute, the 18 months of obstetrics was increased at one point, and the surgical residency was increased to the 4-year program, but solely to account for primary care. This 18 months of gynecologic surgery has never changed, and that's significantly lower than other surgical disciplines. So in response to a variety of complaints and over a variety of objections, the Wilson reforms were instituted in the 1970s. This was an attempt to address quality issues, and to address them, the American Board of OBGYN created gynec, MFM, and REI. At the time, in the 1970s, REI represented the high volume and high acuity surgeons for benign gynecology. But shortly thereafter, Louise Brown was born, and the REIs turned their attention to IVF, leaving a hole that was not filled and has not really been filled. Those of us who have fellowship trained in MIGS, now complex benign gynecology, try to fill that space, but it's not a formal process at this point, and we're trying to create that. But again, it should really be ABOG that realizes that they created a solution, the solution fell apart, and they need to get behind us to recreate the solution that they had created in the past. Of note, again, as I mentioned just a minute ago, there was a 4th year added to the OB/GYN residency, but it was added to train in primary care to capture the primary care delivery for women in terms of annual visits and the like. But as with surgery, because the training in primary care is subpar to the training received by internists, the internists do better with primary care than we do. So we're constantly sort of picking away at what our identity will be as OBGYNs over this history, and we're trying to move into these other fields without really accounting for what it would take to truly master it in each particular space. And we're siloing women's healthcare away with lesser training and lesser standards than the general population is receiving. So this less training means worse outcomes. This is a review paper that we published a little while back, but generally speaking, our gynecologic surgeons are low volume surgeons. 80% of our general OBGYNs operate less than 1 procedure per month, and those low volume surgeons demonstrate significantly increased perioperative complications. It's not to say that volume equals quality directly, but clearly when people are exceptionally low volume surgeons, this is an absurdly low volume for a surgeon, that you would expect them to have worse complications. And this less, and again, the overall morbidity is significantly higher. In addition, because we have lesser training, we can argue less effectively for reimbursement criteria under the RVU system that exists through the EMA that truly accounts for the acuity of care that we provide, because there's such a small number of altruistic surgeons who are devoting their time to providing the high acuity surgical care. It's very difficult for us to marshal the resources to advocate for appropriate billing. Male procedures, urologists are very good advocates for their RVU billing. On average, bill out 27% more than female procedures. And there's been a lot of talk about this. We have another new paper coming out demonstrating that this is absolutely still the case and still true. So with this in mind, I've written a few different papers about how this constitutes discrimination. It's double discrimination insofar as when you have female OB-GYNs, specifically gyne surgeons, those gyne surgeons have lower earnings for female surgeons. Female surgeons earn about 70% of what male surgeons do, including in gynecology. And there's higher reimbursement for the male procedures, as I mentioned, and also, although I don't have specific slides on this given time constraints, pay declines as female representation in the field increases. And this hurts patients because we have lesser resources, we have delayed diagnosis, especially in endometriosis. We have hospitals that invest less time in us, less OR time, less equipment, less staff. It's a snowball effect. And again, as I've mentioned, this is the only discipline where an entire patient population is siloed away from other people who could participate in their care. Unlike the ideal model of a primary care physician that refers to surgical specialists, opening up the door for quality control and the back and forth between different disciplines, general OBGYNs sort of control this circuitous siloed process within gynecology, where unless they refer out, patients might not know what resources they have available to them. This is changing because patients are seeking out the care they need, but they shouldn't have to. It should be in our system to provide them the care they need. Let's compare that to inflammatory bowel disease, which, remember, if you compare to endometriosis, it's 10% of the population, but IBD has 4 times the research budget and 2 times the billing reimbursement because you have 2 disciplines that are involved in this, gastroenterology and colorectal surgery. We should have the same. We should have medical people who are interested in the medical component of treating gynecologic diseases and surgeons who can treat the surgical component of it. And notably also that type of cooperation leads to better care. And so there have been multiple calls for the fact that we need colorectal surgeons and multidisciplinary teams to treat the complexity of care that is needed in endometriosis. I'm all for anybody who wants to highly specialize in bowel surgery, but you need the training. You need to be able to manage the complications. Patients deserve that. So all of this represents systemic discrimination. Just a gentle reminder, and this is a slide defining what systemic discrimination is, but a gentle reminder that systemic discrimination can be unintentional. It can result from systems that develop themselves over time. It can involve very well-meaning people who are still engaging in something that is discriminatory against the patient. We've written about this in the law review article in Emory Law Journal. We've also identified ways forward where we can fix this. And these are a variety of papers that have shown how we could fix this actually quite easily. We could change the methodology by which we create our review systems and increase the billing that way. We could expand the RUC. Note currently on the RUC that determines the RVU systems that OB-GYNs only have 1 vote. We at least need an independent vote for gynecologic surgery. And we could we could reward value-based care instead of simply more care. So we can focus on where we can agree gynecology is underfunded and our patients deserve to have adequately and equitably funded services. And the government does have a duty to address and rectify this under the 14th Amendment and the ACA. Some of our colleagues have gone forward and instead of trying to work within the system to create solutions, they have started to charge patients themselves pretty hefty amounts of money to achieve the care that they need. Is it ethical to do that? No, it isn't. The AMA principles of medical ethics make clear that we need to put patients first, and we need to put them first, including when it comes to financial barriers of access to healthcare. We need to work within existing systems to match our professional ethics. and we need to center our patients as humanistic physicians and not overcharge them. Even if our ethics didn't demand this, just purely from a medical standpoint, debt is dangerous. So people in the United States owe enormous amounts of medical debt. If we're trying to help a patient with endometriosis and thereby creating debt for them, we are hurting their health. The more the debt that people have, the more that this hurts their mental health, and the more that it's associated with more self-rated health. So you can't treat someone and charge them so much money that you create another problem for them. So we have an ethical duty to create these solutions in the current system. And we are working to do that. We are going every year, sometimes twice a year, to the Hill in DC and within our states to try to create solutions to gender discrimination and gynecologic surgical billing. And we've created the Surgical Parity Project, where we're trying to create solutions in this way. So if you go to this website, you should be able to access and share your stories, views, and videos about what our work is, and even have an easy access to write to your congressperson to try to get solutions in place. I hope you'll consider joining us and consider trying to create solutions in this space that can really make a big difference. If you need to reach me, if you have any questions, please reach out to the organizers of this conference, and I'd be happy to talk to anybody who would like to talk to me. Thanks so much for your attention and your understanding. I'm so sad not to be there with you today, engage with all of you and talk to all of you. I wish I could be there, and I appreciate your understanding that I have to be with you.
So I think that we have to conclude. Is Professor Nezhat here? I don't see you. Okay, with this slide. So you will do some remarks. Do we have some time for questions?
If you wish, the audience have been awesome. So first thing what you want to do to clap for yourself. You have been the most amazing people I have seen all day. So bravo. Of course, if you like to ask questions, you are welcome to do it. We will stay as long as you want to answer your questions.
Not a question, but just wanted to make a comment. Yes, I'm the person that was on the afternoon video. I'm Stephanie. So I just want to say thank you for being here. It matters that you're coming together to network, to collaborate, to build knowledge in this space and build expertise in this space. So I just want to say that I appreciate that. And I am now long since more than a patient, but definitely an advocate. So bravo to everyone.
Okay, next we would like to thank the audience, the fantastic panel and scientific committee for putting this awesome program together. Dr. Sayed.
Hi, my question is to Dr. Carlos Simon. Hi. So one of the things I was thinking about when saying about gut microbiome, is it one of the legitimate indications for stool transfer for gut microbiome like we do for C. difficile infections?
Thank you for your comments. Stool transfer, they are just big words. I was not aiming to go that far, but has been useful for, has been shown in obesity in animal models. So this is something also to consider. But more than transfer or just changing, it was a personalized diagnosis to guide our treatments and our way to treat the patients.
So Carlos, fascinating speech you gave, and you probably can guess my question. Those phenotypes that you described with AI, are you planning to put pregnancy outcomes?
Of course.
Okay.
Of course, we should.
I just want to put it like that. So.
We should bridge our worlds. The periconceptional space is where gynecology or reproduction meet maternal-fetal medicine, and we know how relevant is this periconceptional space to understand pregnancy complications and how important it is to prevent, to just look for success. So I think definitively, more than the live birth rates, we have to go to healthy live birth rates, and also for the mother, which will be safer markers for mothers after the pregnancy.
Thank you, Carlos, very much. And for those REIs, let me put another plug that just live births is the minimal actually, because I know that some of you are concentrating on those outcomes, collecting live births, but there's a big difference between having a live birth 23 weeks and 39 weeks. Yes. That's all.
Okay, perfect. So we are a little below about 15 minutes over time, which is good. It means that the day has been very productive. So I will summarize. I'd like to really thank all of you for being here. I'd like the faculty, the participant, the industry. I see some of the industry in the participant. What I was the most impressed, I saw a patient here. She made more notes today than I made it in my entire medical school. So Jenna, I was really impressed. It means that we are doing the right thing. We are going the right direction on the advocacy. And the industry have realized it. I see people from the industry here. So in summary, we learned that endometriosis is not one disease. It's an entity. It could be a syndrome. It could have different manifestations. It could involve any ages. We've learned that surgery is the best choice to approach, but it's not the ultimate. We are going the right direction. We've learned that it could affect all ages. We've learned that it could cause complications of pregnancy. We've learned that it could be affected an immunological disease. I personally am the middle route. I see the legends like Alan, the Cherny, Linda Giudice, Antonio, these are all my professors. And then I see like Helder Ferreira or Vadim Morozov, that they were my fellows. So I'm in between and I see how the trend has gone. I learned from the masters and the next generation is carrying the flag forward. So on that line, on behalf of all the scientific committee, all the Endomarch participants, we would like to thank you for being here. Let's go and have some fun time in the convention. And Cameron is going to say something.
I'd like to thank all of you, as my brother said. The really credit goes to you, number one, that you have stayed to these outstanding speakers that you have. For example, all of the ladies here, gentlemen, and every speaker, like Dr. Wang, Carlos Simon, and the last three speakers, the new generation, Michael Louise, Deborah Lee, and Louise King. All three of them my former fellows. And you see what they are doing. They were very humble. They didn't even say anything. A lot of their experience that they achieved. But they are, each of them in somehow they are changing the world for the better. But if you as patients who are here do not do anything about it, doctors, now each of them are just like you. They are human beings. They have family and they have children. And they don't have, unless they are female, and they are interested in endometriosis, they are not going to do anything, I promise you. So those of you, because I know some of you, for example, Nikita, you are a brilliant woman in AI. And some of the other ones, you guys can do it. But if you don't do it, nobody will do it for you. Today, one patient of ours, because she was interested, she donated significant amount of money. And it would cost probably each person here at least $4,000 or $5,000. But 300 people have registered, but they are not here. And that is your virtue. I appreciate those of you who are here, your families are here, your friends are here, tell them to be here tomorrow. Because that patient of mine, I cannot lie to her. Because there are also 300 people that you paid, all of that, only 200 of them showed up. So please, I appreciate it. Some of you come to the reception, ask your friends to come here, eat food, and then there is going to be more room available with some of the faculty. They didn't bring their wives or their husband. And they reserved it, but they didn't bring them. So there is room for you for dinner as well, for those of you who want. Thank you very much. See you tomorrow. Thank you.